Loretta Rush. I chair the commission every 3 years. We have the governor is announcing the legislative agenda, so all the members of the commission that are on the executive committee will be filtering in. So what I thought we would do is I thought we'd go ahead and start on items that didn't need approval because we're 2 off a quorum. And I thought I'd start with number 6 on the agenda list. I thought I'd have Julie Whitman, our new hard-working executive director, give us an overview of the Children's Commission operational plan updates.
Good morning, everyone.
Good morning.
Thanks for being here. Yeah, I apologize for that. Turned out to be unavoidable timing conflict with the governor's big announcement, and hopefully the rest of the members will be coming in here shortly. So if you want to skip down to item 6 on your agenda, I just have a few updates. I don't have slides, so we don't need to bounce around the PowerPoint, but I have some documents for your reference that are in the handouts. So the operational plan you all have seen before.
These are the documents, correct?
Yep.
It's not a PM.
The operational plan has been presented at each meeting since it was created, and you'll recall if you're at the August meeting, there were several items on there that said pending executive director. So I was sitting there going, I have work to do. So I've updated those. So I would just draw your attention to a couple of them under A2, A2C, roles and responsibilities. There are 2 documents that have been created, the executive committee job description and a set of committee responsibilities to kind of help fill out the roles and responsibilities of each kind of person and group that's involved with the commission. So everybody just has that clarity of what they're responsible for. And there's 2 more pieces that still need to be done. One is my roles and responsibilities. So we have, kind of what was posted for the position, but I kind of want to boil that down. And then I also have thought about doing a roles and responsibilities for commission members because by statute you all are listed as members, but there's not a specific, again, kind of roles and responsibilities. So look for that at a future meeting for your consideration. So that one's in progress. Orientation for new commission and task force members also in progress. I've kind of drafted content for an orientation. I have an outline which I used when I met with Dr. Box, who's our new member, and she'll be here a little bit later. But I want to kind of package it up into a nice PowerPoint and things like that. So that's also kind of in progress. Back of that page under goal B2, B2B, develop a recommendations template. I have done that, and you will see that today because our Mental Health and Substance Abuse Task Force has used that template to formulate the recommendations that you'll see today. I want you to know that even though it's marked as complete, I would really welcome your feedback. It's something that I just put together, but with the intent of getting you all the information you would want to see before voting on a recommendation. So I hope I succeeded, but if there's something else that you think you would want to know, let me know and I can adapt that form. B2C is kind of interesting. It says assign staff from agencies represented on the commission to regularly monitor legislation and present relevant items to the CISC. And then it says responsibility of executive director. Well, one, I don't feel like I have the authority to assign your staff to do things. But what I did do was I convened a meeting of the legislative directors of the executive branch agencies as well as the legislative assistants of our legislative members. So basically the folks who are working day to day with the General Assembly to just kind of get their advice on what's the best way to communicate between the commission and the General Assembly. So that's why that says in progress. I've kind of got some initial notes from that conversation, and I want to formalize that into a little bit more of a plan. And honestly, it'll be a draft plan until after the end of the 2018 session, because I think I just have to live through that session and learn and see how it goes. But I want you to know that there's some intentionality around working with that group of legislative staff and coming up with the best way to kind of communicate back and forth with the General Assembly. Does anybody have any questions on that? That one's kind of a big responsibility.
Of course I don't need that. So.
In the early days, when we started the Children's Commission, just some historical perspective, if you looked at all the legislation, all the different commissions that were topical relating to kids, we had 31 different commissions. Some of them had never met. Some of them had met and then stopped meeting. So we combined them into one. And we'd say, where did this piece of legislation come from? It really does affect multiple agencies that are around the table. So as we work through a strategic plan and put that together, we really want to have sort of that pooling of resources. I mean, we've got our content experts that are on the different task forces, and I think this is part of it. If something comes up and it affects children, affects our agencies or our branch of government, it usually is like in the 11th hour, we all want to weigh in or try to figure out how it is. So I think reaching out and pulling it together so the right hand knows what the left hand is doing to make the best possible is important.
Yep. Okay, moving down to priority C, communication and collaboration. C1B has to do with developing a communications plan, which has been done, and you'll see that later on the agenda for your approval. C1C, actually everything on the third page is really either in progress or haven't started yet just because of timing. So that's kind of the next set of objectives to work on, recognizing our volunteers, figuring out the best way to keep in contact with all those other commissions that are meeting, a few other things on here that are going to get going either in the next month or so or in 2018. Any questions on the operational update?
Can you go through I want to talk about how we start measuring outcomes and impact and what we're doing on
Yeah, so I have an idea, but it's a very early idea on that, but I'm pretty excited about it. As you all know, I'm a big data geek. And so in terms of measuring outcomes, and this came up, one of the other documents that I had put in your packet is a kind of a summary of what I heard from you all on my listening tour. And this idea came up, it's under Be Data Driven, the idea of sort of coming up with like an outcomes dashboard for the commission's work. So what really are the indicators for kids that we're trying to change, and how do we know if they're changing or not? And what would be appropriate to this group? Again, each individual agency has tons of data indicators they're looking at, but what would we pull together just for this group and just for vulnerable youth as they're defined in our statute, and then kind of keep track of that? So I've actually started an initial conversation with NPH about pulling together a data group, a stakeholder group, to start defining what that might look like. So that's my early idea on outcomes. More specifically around...
Julie.
Oh, sure.
Is part of that just kind of giving us a dashboard of what that vulnerable population looks like? Who it is, where are they, where are they connected, because they're connected with multiple agencies.
Right.
Because I think that would help. And then anything that I think we do, certainly outcomes are going to be a ways down the road. But
Right,
some
right.
starting point from
Right, you
what's the
begin
current
with the
picture.
baseline,
Right,
right?
okay.
Yeah, absolutely, and then see how it changes over time. And the first thing is, and why I went to MPH, is getting the records together, right?
Right.
So you can even see where cases cross agencies,
Sure.
right?
That's what I wanted to make sure, that when you do this dashboard, that it clearly delineates which agencies are responsible, so that we can see where the cross-section occurs, and we can see who is in charge for whatever reason, either legislatively or because it's the responsibility of their administrative responsibility, but who is responsible for, what agency is responsible for this set of data points. And then we can see where they cross, or maybe it's not the right agency or whatever.
Right, right. There's so much potential for looking at all that cross-agency data. Even fiscal mapping is another idea that came up kind of in the listening tour. So I'm going to have to control myself on how many projects I start. But I think there's a lot of fertile ground there in looking at what is each agency doing, where can we be more efficient, where can we combine efforts? You know, if we have similar efforts going on in 3 places, does it make more sense to pull them together? Here's a very, very small example, but just this morning at our task force chairs meeting, we discovered that every single one of the 4 task forces is looking at trauma. I think Child Safety and Services is the only one that has explicitly in their objectives, but you can see where it fits into the objectives of all the other task forces. So we decided to pull together at least one person from each of those task forces to talk about trauma together. So we're not each going off in different directions.
Different silos, yeah.
What can we do together?
Yeah.
So I don't know if that answers your question, Chief Justice Rush. The other, that's sort of long-term outcomes, right, and data, but there's also process outcomes. So what have we agreed to do, either as a group or within our own agencies, and then how do we report back on whether that was done, which was another idea that kind of came out of the listening tour. So kind of holding ourselves accountable to the actions that we have said we're going to take. So that's another thing that probably needs to be sort of spelled out a little bit.
Good.
Any questions on that one? I also included in here for you, and the executive committee has seen this a couple of times, my own little 30, 60, 100-day action plan that I just kind of created to focus myself. And most of that really comes out of the operational plan. I looked at that and said, okay, these are the things I need to make sure I accomplish, and then I added some additional things that I thought would be helpful. So I'm not going to go through that in detail.
I would go through it. I mean, I think it'd be helpful, because I know, I mean, I meet with you, so I know some of the things you do, but I think it'd be helpful for
Okay.
for you to go through the work that, I mean, you've been
And
on
where
the
is
job for X amount of time.
Uh-huh.
What are you working on? What have you completed?
Yeah, I think it's about 7 or 8 weeks. I don't know, I lost track. The first 30 days are over, so everything kind of in that bucket is complete, although, you know, one of those, connect with other relevant state government commissions and committees will obviously continue to be ongoing. So I made some of those connections within the first 30 days, and I intend to continue connecting. I'm going to attend tomorrow the drug task force meeting to make sure we're connecting on aspects of that involve children. So just that ongoing work of coordination. Met individually with all of the task force co-chairs, except for one who is out on maternity leave, so we'll connect soon. Kind of have been working on assessing the progress against the strategic objectives, which was the bulk of our chairs meeting this morning. I have a tool that I've put together. It's not quite ready for this group yet, but the chairs are working on filling in for each of the objectives that their task force is working on, kind of what's the current status, what action steps are they taking. Because to me, one of the things I've interpreted as an important piece of this role is moving that strategic plan forward, right? So the commission created a strategic plan. How do we know what we're accomplishing? How do we kind of keep things on track? So created a tool for that, kind of have been attending all of the task force meetings, and I intend to continue doing that, to just know what's going on across the board and help make connections. Thanks to you all, I've completed the listening tour of you, and there's a summary of kind of some of the things that I heard on that tour, which was great.
Could you go over those?
Sure, we can jump to that. So the listening tour summary looks like this. It's just a Word document. And obviously, I asked all of you the same questions. Everybody has a different perspective because of your role and because of who you are. But there were a few things that I heard in common, not necessarily from everyone, but from enough people that it made sense to kind of highlight them. So the first one being focus on achieving the results. You know, let's be really clear about what we're going to deal with, and by extension, what maybe we're not going to deal with, or we're not going to deal with right now, or maybe we'll, you know, look at that for the next strategic plan. So kind of staying focused, being data-driven, I already mentioned, in terms of sort of evidence-based decision-making, looking at our outcomes, that sort of thing. Several of you commented on the important leadership role that this group has and can continue to have by virtue of the leadership roles of each person on it. So this is a very powerful group, and the collaboration within this group itself is also very powerful. So I was encouraged by you all to keep thinking about how to leverage the power of this group for the benefit of kids. We also know that there are political realities. That's part of the nature of government work. And so it's the key there to me was, but nobody said we shouldn't do this because it's too political, right? Everybody said we can do this as long as we're aware, right, of what the realities are, and we focus on building consensus. There are common sense things that we can do for kids together that we can all agree on. And it goes back to kind of the data-driven and the evidence-based. Several folks mentioned using that commission as a vetting body for child-related legislation. Also, it was brought up even, you know, if people have funding proposals, I don't know if we're there yet to be vetting those as well. But that kind of idea of this group as sort of a good housekeeping stamp of approval on things that have to do with kids before they go to the General Assembly. And I expect that will come slowly over time. I hope we'll start to do that well, we've done some of it already, but that we'll do more of it this coming session and even more the next year. A few comments around the structure and timing of the meetings and keeping up communication between meetings, so kind of some of those administrative things. And then lastly, kind of the need for greater awareness of the commission, both within state government, particularly with the General Assembly, but even with some of those other government bodies, and then the need for greater awareness out around the state. So what does somebody in Evansville know or care about the commission? What does somebody in Kokomo know or care about the commission? So trying to figure out how to kind of get not only statewide representative into the task forces, but also maybe get me out around the state a little bit. So
Why don't you talk about, you said you had several people say instead of 4 2-hour meetings, having more frequent, 4 4-hour meetings a year, change it to every other month or 2 hours. Why don't you, while we've got a group here,
yeah,
what are your thoughts on that?
what are your thoughts? I mean, several folks commented, and obviously, stuff comes up, but it's hard for people at your level to make time for a 4-hour meeting.
Yes.
And the other comment that was made kind of together with that is it's also hard to build momentum when you only meet quarterly. So what if you had a shorter meeting like a 10 to 12 and it was every other month instead of, you could even by extension have a 1-hour meeting every month. I don't know, and all of those would be the same amount of time, but it's kind of what you want to accomplish and what we want kind of the rhythm of the group to be and what works for your schedules.
Are our meetings legislatively stated, or how did we end up at 4?
By statute, the chair schedules the meetings. The commission chair establishes the meeting dates.
So you established these 4-hour meetings?
I did, yeah, I did. I did. And sometimes I regret that. We've had wonderful attendance. We've had 80 to 95% attendance. It's unusual because we've got a conflict with the executive branch today as they roll in. I'm fine with going to 2-hour meetings every other month. A lot of the core work gets done in task forces. Our task forces are meeting monthly. Yeah. And then they bring that report to us. But, 4 hours is rough. It's rough. So I think that we decided as a whole to meet 4 times a year. What are all your thoughts? I mean, I would be fine with every other month, 2 hours.
I like every other month, 2 hours.
2 hours. Anybody?
Yeah, I would agree with that.
I don't have a problem with that.
I think it keeps the momentum. It does keep the momentum. Sort of keeps this on our mind, and gives us a forum to talk about the things that come up when they come up.
We do have, we have monthly executive committee meetings that you will be getting the minutes of, and if you see something on that agenda and you want to come, we had the budget director there at the last one. We've had the Attorney General's office there at it. So you're welcome to come. Like if you see something in education, you want to send somebody up to that, you can send a designee to those. So we will have the monthly meetings, but to have this meeting every other month, as soon as we get that quorum here, we will vote on that. But
Right.
Is that the consensus of this group every other month?
2-hour time block is easier to
It is a lot
forgive.
easier. It is.
It's a lot easier.
Unfortunately, we're missing both our current chair and our 2018 chair, who officially by statute have the authority to set the meetings, but there you go. Okay, good. Well, so we'll just bring it back to the 2 of them, and then we'll kind of reconfigure. So we have 2018 dates set, but obviously we'll change those. Probably at the next, there's an executive committee meeting scheduled for December 12th, so I would anticipate at that meeting we'll lay out the 6 instead of 4 meetings for next year. What else? I think a lot of the rest of what's on my personal kind of to-do plan, again, was reflected in the operations plan. And, things that my ultimate goal is to finish everything on this list before Christmas and come up with a new list. So, in terms of, it probably won't be this detailed, this was really kind of to get me going, but I will have some goals for myself for the first quarter of the year, which encompasses a legislative session. So what's that going to look like? And then some goals for the next quarter on, maybe some of these additional projects that I'd like to get started, like the outcomes dashboard idea or the fiscal mapping idea. Kind of pick some priorities and lay out some goals that I'll share with the executive committee at the December meeting for 2018.
All right, thank you. I think we're going to go into Kathy Graham from IARPA is going to give a report of the legislative assignment to study licensing requirements. We may have to summarize when we vote, but I know she's got time constraints, so why don't we, Kathy, you ready? And if you could give a summary of the assignment, kind of give us a historical basis that your committee looked at this issue and describe the issue.
Certainly, Madam Chairman and members of the Commission. And let's see. This Commission was asked to study the barriers to professional licensing that are leading to a shortage of what it said was child care and child abuse providers. And we did go back, IARCA, the organization I represent, which has 91 providers as part of its membership. We did go back and check with President Pro Tem Long's office to make sure that child care designation meant residential child care and not child daycare. So we did clarify that, wanted to make sure we were appropriately within the task force studying what we were asked. And so we did a survey through our committee. We developed questions, and we'd already been looking at the workforce shortage and the shortage of providers, particularly for the Department of Child Services, Children and Families. And so we collaborated, IARCA did, with the Indiana Coalition of Family-Based Services, and we developed a survey. We had 54 agencies respond to the survey, and they provide home-based services, foster care, and residential treatment to abused, neglected, and delinquent children and their families. So you have a summary in your packet as well of what we found, but we'll go through the PowerPoint if that's all right, Madam Chair. So the 54 agencies reported that they had 1,136 staff members who were required to be licensed. And licensing is fairly complex, but generally we're talking about licensed social workers, licensed clinical social workers, licensed addiction counselors, licensed marriage and family therapists, and licensed mental health counselors. And we'll talk the most about the licensed mental health counselors. Of the 1,136 staff members who are required to be licensed, 715 were master's level therapists, 255 were case managers working with the children and families, and 166 were other staff members who would be persons who by law are required to be licensed because of their degree and their activities in administration and so forth. They reported the average wait time for a temporary license, this was the most common response, is at 30 to 60 days. So once you complete your graduate studies, you can get a temporary license while you're waiting to take the exam. And so we found that that was the average wait time. And I will say that since the Attorney General's office began really enforcing and taking action against unlicensed professionals around 2014, there's been a much greater emphasis in the programs and schools of social work in particular to make sure that their graduates know to work toward their temporary license because of this lag time. But we still have a catch-up group of people who had been practicing. There had been some grandparent clauses. It had been a very kind of confusing time as to whether they needed to have a license or not. And so we still have a group of people who are trying to catch up, who may have graduated a number of years ago with their master's degree in a various program related to clinical work. The average wait time then for an initial 2-year license is around 30 to 60 days. That was the most common response. However, some licenses have taken more than 180 days, and that will relate to some of what we're reporting further into the study. And some of those individuals get a temporary license and then they are not able to pass the exam. The exam has a failure rate of about 30%, so only about 70% of the individuals who are taking the exam pass it on the first time. I'll just keep going, Madam Chairman, unless someone has a question. Factors that delayed licensure, and this is a report by the number of agencies, so this doesn't represent the percent of individuals. It is how many agencies had at least a staff member affected by a delay in licensure. So people who had to wait more than 2 weeks to take the exam, that was 69% of the agencies, which is actually works out to 38 agencies. A number of individuals had to submit a syllabus to verify the coursework. The statute includes what kinds of courses they've had to take, and if their transcript isn't clear that they had that content, then they have to go back and get a syllabus. And Dr. Dale Wayman from the Indiana Counseling Association testified before our task force that he, with a PhD, had to go back and find a syllabus from more than 20 years ago. Luckily, his professor was a professor emeritus and was able to get a letter saying he did have that coursework in that class. But you can imagine trying to find your college documents from 20 years ago and a syllabus. So that has been a difficulty. Submitting additional paperwork to verify internship hours was reported by 49% of the agencies. Had to complete additional classes for LMHC licensure, which is the mental health counselor, was 47% of the agencies had at least one staff member with that difficulty. And what we found was that there are 2 accrediting bodies for counseling programs in master's level, and there's a third one being developed, and they have differing requirements in terms of the number of class hours, and then they also have differing internship and supervision requirements, particularly for the licensed mental health counselor. So we'll have some recommendations around that. And then 40% of the agencies reported they had to submit additional paperwork to verify clinical supervision hours. So those are around 2,000 hours that people have to provide documentation for. Factors also delaying licensure, and our task force and committee has worked with the Indiana Professional Licensing Agency around some of these. IPLA phones were not answered or callers were placed on hold for several minutes. 40% of the agencies reported that. Their license application was lost and had to be resubmitted. 38% of the agencies reported that had occurred. Other was 35%, and those examples included that they got different responses from IPLA. Some documents were lost in addition or besides the application. That included some people's test results. So there were these kinds of things that delayed people getting licensed. And then having to complete additional internship hours for the licensed mental health counselor license. More commonly, that one of the accrediting bodies requires only 700 internship hours. Indiana's law requires 1,000 hours, and so people were graduating with a master's degree in counseling from this one type of accredited program, and they were told you have to take 300 more hours of internship in order to be eligible to take the test for a license. So that has been a big barrier for those individuals, and some have left Indiana and gone to practice in other states. Having to complete additional classes for another type of license, having an issue that has to come before the Behavioral Health and Human Services Board, and it's on their agenda, but the board ran out of time at their meeting, and so the issue was postponed till their next monthly meeting. They typically meet monthly, although last year they only met 9 times. And they had to complete additional internship hours for a different type of license. So these are some of the things that have been delaying
Wow.
people getting a license to practice, so that, you know, and some of this has occurred, people will have a temporary license, they're working with 12 families, and then if they are not able to pass the test, their license expires on the date you failed the test, so you have to figure out what to do with reassigning those 12 families until the person can be licensed again. So we also looked at the use of virtual supervision for part of the required face-to-face supervision, because the license that a clinician is pursuing has to match with the license of their supervisor. So an LCSW applicant has to be supervised by an LCSW qualified supervisor. Sometimes in an agency you might be working for an LMHC, so you have to go find an LCSW who can supervise you. And overwhelmingly, the agencies reported that it would be helpful to have virtual supervision for up to half of those required hours.
Yeah, I just gotta back up a little.
Sure.
This is not good news. You're saying that 40%, they're losing applications 40% of the time, and then 40% of the time, the surveys, they're not.
No, let me clarify, please. 40% of the agencies had at least one staff member where that had happened to that staff member.
Okay.
So not 40% of the time, but it is 40% of the agencies. So that would be,
40% of the 55 agencies.
yes, so it would be 22 agencies had that occur.
And everybody that you surveyed agreed that we have a shortage of providers. I mean, that's why we tasked your
Yes.
group with doing it. So
Yes.
we're looking at, you sort of did the deep dive to just find the barriers to getting providers, because I think everybody agrees
Yes,
we are in a pretty severe shortage of providers.
yeah,
Okay.
yeah, yes, certainly. Thank you.
I also
Good
have
morning.
a question. Good morning, thanks for being here. The face-to-face supervision and the use of virtual supervision up to 50% of the required hours, is that something that you determined would need a legislative change or could be enacted under a rule? Is that going to be part of your recommendations and yet to come, and we can talk about this at the end, or that just drew a question to me at this point in the presentation?
Yes, we will be making a recommendation for a legislative change for that, and so we have some proposed language for
Great.
you to consider.
Thank you.
So here are our recommendations. Would you like me to proceed with those?
Very good report, though.
Yeah.
Thank
Very
you.
good. Very
Well,
enlightening.
it was a team effort.
And just before we move on, your point here about rural areas having difficulty, that has been certainly something
Same
I've
here.
heard a lot about in my own district from people who are trying to get through this process and having difficulty finding, you know, that parity of a supervisor.
Yes. Thank you, Madam Chair. I need to just also say, in addition to working with Dr. Dale Wayman of the Indiana Counseling Association on these recommendations, we did consult with members of the Behavioral Health and Human Services Board, particularly around the virtual supervision and some of those things. And so we had talked with 2 of the social work representatives, 2 of the LMHC representatives, and the chair of the board had also contacted us. So we have tried to informally reach out to that board, as well as working with the IPLA. And I will, to get to your point, Chief Justice, I will say what IPLA has tried to do to address the concerns that we found.
And that, because we're going to be making, this body will be voting on this, the historical background on who all you consulted with regard to your task force to make the recommendation, that was very helpful.
Thank you.
Are they in agreement with recommendations, or they were just consulted on?
The board does not take a position on legislation, I'm told.
He was testing you, that was good.
It just helps to know when you get this in front of a committee, who's going to be there to talk. Yeah, okay,
I think the state agency may be who will be there.
okay.
But we certainly appreciate that the board members see when things go wrong, and they see the issues that need to come before the board that may have to do with less than good practice. And so we wanted to be sure we also were consulting with the board members around what they're seeing and what they might be supportive of. So this is basically those board members speaking with us as individuals who volunteer on that board. So our first recommendation is to amend the statute regarding the LMHC licensure to delete 1 advanced internship of 300 hours. That would bring us down to 700 hours, which 30 other states have either that or a lesser number of hours in their statutes. So, and that would put it in line, Indiana in line with one of the accrediting bodies that does the counseling and school-related program counselors in master's degree. Then proportionally, we would reduce the 100 hours of face-to-face supervision, and we would ask that that be 66 hours of face-to-face supervision, which is roughly the same ratio. When you take out 300 hours of an internship, you need to reduce the face-to-face supervision hours. And that, again, would put us in line with those roughly 30 other states. So that's our first recommendation. I don't know if you would like any.
I think we'll go through all of them.
The next one is related to the virtual supervision, is to add language that virtual supervision by a qualified supervisor may account for up to 50% of the required supervision hours. We didn't want to be overly prescriptive in this recommendation and give some latitude to the state agency and the board around the parameters of how they may implement that. But we did want this to be added to the licensed clinical social worker statute, the LMHC, the licensed marriage and family therapist, and the licensed addiction counselor statute. So those are all referenced up there. And that would allow, again, those seeking clinical licensure to more easily obtain that by removing the barrier related to distance for up to 1/2 of the required hours. And those hours are, for supervision, are 96 to 100 hours in the statute. Concerns regarding insufficient staffing for the licensing of behavioral health and human services professionals have been addressed by IPLA. They presented at our task force meeting in October that they have added 1 customer service representative to the current staffing, and they have changed their phone system so that it will roll to another customer service representative if the wait time reaches 3 minutes. So instead of people waiting for minutes and minutes, it'll roll to another person. So they have attempted to respond to those concerns. And then another recommendation is that there be a study of the ability of licensed clinical social workers, mental health counselors, marriage and family therapists, and addiction counselors to diagnose and provide treatment as independent practitioners. And we had quite a bit of discussion in our task force around this recommendation. Currently, there is a shortage of HSPPs, which are typically PhD clinical psychologists and psychiatrists who diagnose and sign off on treatment plans, and that is occurring especially in those designated health professional shortage areas. So this people can be on waiting lists for weeks because there aren't sufficient professionals to sign off on those treatment plans and to verify the diagnosis. This is something that would take quite a bit of study. We would need to look at other states and what are they doing. But Dr. Wayman testified that he had worked for the VA for 20 years. He has a PhD in counseling. He helped to develop and test certain assessment tools. And in Indiana, he is not allowed to use those assessment tools to diagnose someone. So, and in many states, there are criteria for independent practitioners to be able to diagnose and provide treatment without the oversight of an HSPP or
But that's not, your recommendation is that you would like, the task force
Study.
wants to be able to do further
to study.
study.
Yes.
All right.
Yes, to study. This would be something we would envision next year, doing next year. And then in addition to those tasks, we are working on some other things within our committee, and I know Mindy Goodpaster will report on the other committees. As you said, as you noted, Chief Justice, there is a lot of work going on in the task forces and in the subcommittee. So we are surveying the community mental health centers right now to find out where they are providing school-based counseling and where are there barriers to providing school-based counseling.
So the recommendations you have,
I've got a few questions. I'm going to refer back to the slide about IPLA's response time.
Oh, sure.
And I'm wondering if the task force could report back if there's been an improvement in response time after these things have been implemented and used for a short time period. And I don't know what we want to have that be, 6 months, I don't know. But if the task force could report back to the commission just if that in particular has had an impact, if it's making a difference on that increased response time from the agency.
Yes, I'm sure we would be glad to do that.
And then on the study of the recommended ability to provide treatment as independent practitioners, the next slide. My question is, in your study, did you anticipate whether that would extend to the ability of those practitioners to provide for prescription medication within those treatment plans, or would that still, in your estimation, be under a psychiatrist ability?
We did not
You
discuss
did not explore
that.
that as part of treatment, providing treatment.
I think we were thinking more of therapeutic interventions that are not medication, but are more your
So they
traditional
could go ahead and
therapy.
diagnose an issue and then begin a treatment plan,
Right.
but not be able to prescribe medication for
Right.
that.
We didn't. I don't think we planned to go there.
All right, that's
but
just a
that's just me.
clarification
But we did
under
not.
what falls under providing treatment.
Right. Yes.
Okay,
Yes. Yes.
thank you. Are there any other questions? Yes, Senator Bro.
Thank you. it seems as though Indiana's requirements relative to other states is higher. And, for example, when you want to reduce the 300 hours and just allow the 700 to be sufficient, are we aligning ourselves with programs that are less than what Indiana typically would require, or are they essentially the same and they're just able to do more in a shorter period of time? Because, I mean, I'd hate to see us dumbing down, but I also know we need to streamline the process.
Yes. We really were concerned and wanted to know more about that because we had heard there was this discrepancy from Indiana's laws to the accrediting bodies for masters in counseling. So we did talk with, I in particular talked with the two LMHC representatives who gave me some history on why the Indiana statute is what it is, and at that time they believed that they were moving forward with where the accrediting bodies were going with 1,000 hours of internship. But the one called, it's called CACREP, but it's really CACREP, the Council on Accreditation of Counseling and Related Education Programs, set their criteria at 700 hours. And there are a number of Masters in Counseling programs in Indiana that are CACREP accredited. And so in the course of the last few years, I've talked to a number of individuals who said, I've got my Master's in Counseling and I go to get my license and I find out I have to take 300 hours in an internship and have these additional barriers to actually getting out there and practicing. And we have lost some of those individuals to other states.
So I guess my question is there a good reason for that? Is our program a stronger program or a better program, or are they equivalent and just can be reproduced in a shorter period of time without that additional 300 hours? Are we losing something by not requiring people to get that 1,000 hours and settling for 700?
I think certainly there is a loss related to the training you might get in those 300 hours. I think the trade-off is, do you have people who are prepared to be on the job when they graduate, and they'll have their 2,000 hours of postgraduate supervision to get their clinical degree or their clinical license.
So essentially, the folks who get those 700 hours are equivalently trained to those that get the 1,000 hours. So that there's not, yes, there is a loss in terms of hours, but fundamentally the core, the basis of their training allows them to be able to do what we need them to do at 700 hours.
There is some difference among the profession around that, because some of the programs came out of psychology, and those programs are accredited by a different organization, and the CACREP came out of more counseling programs. And what ends up is the LMHC credential is sort of a group of degrees of different types of counseling and psychology master's degrees. And so we have this discrepancy in who accredits them. So what we did was look at, well, what are other states doing? If we are losing people to other states, and we looked at 30 other states have it at 700 hours or less, given that we have the postgraduate requirements for clinical licensure. And I did talk with the licensing board individuals about this, and they felt like 700 hours would be appropriate.
It would be sufficient.
And
we
Senator
would-
Breaux, if I may, this is an issue if we decide to adopt these recommendations for recommending this type of legislation. Those are issues that we can work out in the legislative process when we have experts to come and testify about the pros and cons of that
Okay.
system.
Then my other question is, in IPLA, so we addressed the phone and the wait time, but what about the lost documents and all of that? There seems to be some problem administratively or organizationally within the IPLA. Is there some way that we can help, or is that outside of our purview? Is that something that they?
I think having brought that to their attention and adding the customer service representative, hopefully you would have an additional person to be managing those documents so they're not lost on someone's desk or something like that. So I think following up and seeing if it makes a difference in that as well, and what we might even consider doing is resurveying the agencies to see if that goes down.
Yeah, because I think that lost document is probably more important than the wait time on the phones, because that's actually what's delaying folks getting their certification.
Yes.
And then my last question is this virtual supervisor. Is that a proven, is that something that actually exists and can be tracked and is a valid way of doing business?
I am told that Illinois is using that, and we're working with the National Association of Social Workers to find out in what other states are they using that and how effective is it. But it would be a virtual, not telephone. It would be a face-to-face using technology, and
Okay.
with appropriate
Okay.
confidentiality, you would have to take that into consideration.
Well, I'm all for moving it forward, but I just don't want to
Yes,
degrade the
right, I
programs
understand.
at all.
Yes.
And the folks who are providing the services.
Yes, I agree.
Thank you, Senator Bro. Representative Summers?
Hi. You made a statement, well, it was one word, about the number of hours that is currently in statute. You said anticipated. When this law was first enacted, it was anticipated that it would go up to that much, these many hours of requirement.
Yes.
So now, we know now that they don't need that much. Is that what we're getting?
I think that as I understood it, they thought all of the accrediting bodies would have 1,000 hours. The groups that provide accreditation studied it, and one group set theirs at 700 hours. So I would have,
Okay, so the percentage of people that, is the percentage of people that get accredited by the one group that says 700, is it somebody, I guess my question is, what percentage of people get credited by that organization?
I don't have the answer for that. It's by the number of types of counseling, masters in counseling programs. So it's more typically those programs and masters in counseling versus masters in psychology, which would have the 1,000 hours. But I don't
Okay.
have the number.
I understand. I understand there's two different distinct,
Yes,
it's counseling
yes,
and it's
Yes,
psychiatry.
and they have to try to fit in the same basket of
Okay.
this is the definition, so.
Thank you.
Thank you, Representative Summers. Mr. Moore, as the Director of Mental Health and Addiction, I'd just like to get your input in the overall discussion on these recommendations, if you'd care to weigh in.
Well, I think hearing from the licensed groups, the stakeholders on the hours, I think will be important. I think when you go from 1,700, is there any more additional learning in that 300, or is it just more practice under supervision? And if that's the case, is there the ability to have a tiered process, or that could complicate things even more? But I think taking a critical look at that level of supervision, those number of hours, I think is worthwhile. And if that gets people through the process quicker and on the floor, able to work, I think that's important.
And I think, I guess another question for you would be, and maybe for the commission, I believe these are issues that if we do end up with legislation toward this goal, that those are issues we can vet through the legislative process on what those best practices should be
Yes.
to try to get to the goal.
Right.
And that should not impede our ability to approve of, if you will, or if you have other concerns, that's certainly well within the bounds to discuss. But that consideration should not impede our ability to approve these recommendations.
I agree.
Okay.
Yeah. And I like the take a look at the virtual supervision, and that really helps in the rural parts of the state.
Sure does.
That's assuming there are people who can do that, who are licensed in Indiana to do that, but I think it's worthwhile, again, to take it through the process to have that discussion.
Thank you, Mr. Moore. Any other questions?
When you said weeks, I mean, I'm saying months to get, usually it takes weeks to get a child within the system into treatment. I'm saying it's months. I just didn't know if you, was it that sort of just anecdotally you said weeks? Because I'm hearing from judges and probation officers that it's months.
Is it
to get
more
it.
than
Can
4
be
weeks?
months. Yes, Judge.
It's months.
Yeah, it was, what we had been hearing was, like for community mental health centers, it would take, they would have a 6-week waiting list or longer. I was just, yes.
It sounds like your committee put a lot of work into this. I mean, solving
Yes.
a lot.
Yes.
If you could,
Really good
put
job.
appreciation back, that's a tough issue.
Yeah.
Yes. Thank you.
Any other questions? Before we ask for a motion, I also just want to express appreciation for the work of this task force. It's been a tremendous help moving. I know we've had several pieces of legislation that came out of this task force for last session, and again, we appreciate the work of the task force. Representative Summers.
I would just like to lend my services in the next session to run this through, please.
Yeah, how do task force, how do task force get formed? Are they members of
There
the
are.
commission, or?
Their content, no.
No.
The chair picks the chair of the task force, and then we rely on, there's a broad, executive committees can recommend
Okay.
people, but we look at what do we need? Who are content experts in this
Okay.
area?
Very good.
And then we populate. Like, could you give us a quick overview of who's on your task force?
Certainly. Our task force is chaired by Senator Randy Head and Priscilla Blackman, Deputy Director at DMHA. We have 3 subcommittees, and Mindy is reporting on 2 of them later. But we have the representative from the School of Social Work, the CASA program. We have a Community Mental Health Center on our subcommittee, as well as a foundation, the Lutheran Foundation, on our subcommittee. We did have a youth representative, but she got a promotion, and so we have to find another youth representative. So that's our subcommittee. I know on the others, there's Department of Correction,
Okay.
Medicaid,
that
a
makes
lot of
sense.
different, yes.
Between the task force and the subcommittee, sometimes there's dozens of people working on different topics.
As volunteers, right, volunteering their time
great.
to this
Okay.
work. All right, any other questions? Do I have a motion on the approval of these recommendations?
Move to pass?
And is there a second?
Second.
All right, all those in favor say aye.
Aye.
Any opposed? All right, we have adopted your recommendations. Kathy, thank you very much.
Thank you, Madam Chair.
Thank you, Kathy.
Thank you, Commissioner.
Let's go back, we have a quorum now, so we need to go back to the approval of the minutes from the August 16th, 2017 meeting. Has everyone had an opportunity to review the minutes?
I move that we approve the minutes.
Is there a second?
Second.
All those in favor say aye.
Aye.
Any opposed? Okay, thank you. We will move on to Ms. Goodpaster for the next portion of presentations from the strategic priority on mental health and substance abuse.
And Dr. Walter, we just approved unanimously a change of recommendations with regard to licensing hours, just to bring up to date with recommendations for approval.
Thank you. Thank you for joining us, Dr. Walter.
Good morning, Madam
Page
Chair.
8, correct? Page 8, Systems Gap Subcommittee.
Yes. So there is a section in the PowerPoint, and then you also have a section with some documents in the further reaches of your handouts. So, good morning, Madam Chair and members of the Commission. My name is Mindy Goodpaster, and I am the Public Policy Director from McCoy, the Marion County Commission on Youth. And I'm one of the original members of the Mental Health and Substance Abuse Task Force that was created by the Commission. So today I'm going to report on some of the other committee work We have a couple of recommendations, and then we have some other areas of study that I'm not going to report on necessarily right now, because we felt that the study was worth taking more time to do before we came up with recommendations. And some of them actually might make more sense to do in a budget session.
Are you going to be making recommendations for our approval today, separate from the ones that you want to
Yes.
delay? Okay, thank you.
Yes, because this is based on different work from other subcommittees. Yeah. So what you'll see is that we've got two recommendations that are coming out of our subcommittees, and this is sort of combined from both of the subcommittees, both the services accessibility or service creation subcommittee and then an access gaps subcommittee. So one of the recommendations we're going to talk about is how to guide programs, particularly within the Department of Corrections, to guide service providers on how to select an evidence-based program. We know that a lot of resources exist regarding evidence-based programs, but there's a lot of confusion about what that means and how do you pick a program that is going to fit within your population and fit with your current expertise. And then secondly, we're going to require a survey for all licensed mental health professionals when they renew their licensure to gather more data that we are currently missing. So let's go to the first recommendation. One of the members of our subcommittee is Mark Neola. He's the Youth Services Program Director at DOC. And what his concern was that the folks that he works with really don't know how to pick and don't know where to access the programs and the resources to serve the children that they see, and then how to refer them out to good programs, to evidence-based programs in the community once they are released from DOC. So what Mark developed, and this is a handout that's in your packet, it looks like this, it's just one page, was just a quick how-to guide that shows a few resources that he feels, are the best resources for the programs that he's talking about or would look at.
Do you know what?
That's the handout, yep. Yep. And it's based on something that Florida did that he thought was a really comprehensive guide that would be useful. And he wants to post this.
That's fine. Take a moment to find these.
It's in there. There's a lot of dividers and things, so it's after one of the green dividers. It's probably about midway through, I think.
Evidence-based programs of practice.
You can go ahead.
Okay. So basically, we just want to find somewhere on in.gov to post this document so that it can be accessible to everyone when they're looking, and that can be beyond DOC. It can be, anyone can use this guide on how to select the evidence-based program. So the elements of the guide, I've put some of these in the presentation. The first part would be the resources that he recommended, including the websites of how to find them. These are the resources, sort of the national clearinghouses that offer the programs and how to select the program. So what does the program do? Who are the populations that it serves? What type of time frame are you talking about for the program? That's what all is included in all of these different national clearinghouses. And we're talking about, prevention programs, we're talking about intervention, we're talking about substance use, we're talking about mental health, we're talking about the whole array of services that we need for these youth. And then there's a link to the Florida guide, which really, I looked at it and they updated it in 2015. It's a really comprehensive guide that is used within their Department of Juvenile Justice. And it's a great model, and I think that, everyone can benefit from going there and taking a look at it because it really thoroughly lays out, what are some of the best practices for youth within the system. And then the second part of the guide are the elements that basically just quickly explain what it means to be evidence-based, what it means when you're trying to select a program, knowing how to select the program that's appropriate to your audience. Certain programs are geared towards certain age groups, certain programs are geared toward different grades. They have to be implemented by different professionals. They deal with different subject matter. So just knowing how to navigate that, what does that mean? And how do you select the best program that fits your personal, audience or your program or the constituents that you serve? So basically, that's the information that Mark felt would be really, really helpful to post online so that professionals could access it whenever they needed to. Okay? Any questions about that part?
Ms. Blessinger, do you have any questions in particular since you are from DOC?
We've been having lots of discussions just about programs and services in the department, in our division, about whether or not, just because a program isn't evidence-based practice, is it best practice, does that mean it's not a good program? Those are questions that we've had. As far as this document is concerned, I'm not real familiar with it, I'm going to be honest with you, so I'm going to need to look at some of
Certainly.
this.
Mr. Powell?
I'm a little confused, to be honest. Maybe I'm the only one, but you're wanting to post these websites on one of our websites and say these are recommended resources for you to consider in your programming. Who is this targeted to? Who are you speaking to here?
Well, initially, Mark envisioned that it would be staff of DOC.
And do you know if DOC has looked at each one of these areas and whether they agree, disagree, have considered this?
Well, Mark would have to answer that. I can't answer that for him. But I was under the impression in our conversations through our subcommittee that this was something that was a conversation that was happening within his realm, so that I can't answer.
It just seems to me if DOC is on board with this, why would we have to tell them to do it, right? I mean, they ought to be doing it anyway. And, I'm head over heels in EBDM, right, in my other committees. And candidly, there's a lot of different opinions about that. Let me just say that. And there's lots of folks who say it needs to be evidence-based, research-based, validated, all these, fancy terms. And yet here we are, and I'm being told there's a lot of work to be done in that area, and we're sort of leading the way in Indiana in some way, and yet you've identified 5 places that got it figured out. I'm thinking, why are we wasting our time in Indiana talking about it if we just got to go to these websites and download what's already been. I'm just a little concerned about that. If it's your recommendation, I'm not sure I'd want to jam this down DOC's throat.
So the resources, with the exception of Florida, these are all widely known national clearinghouses. So these clearinghouses don't say one program is preferred over the other. What they do is they rate them, they evaluate them, and they rate the programs, and then they present the information.
And who's they?
The government. In most of these cases, and also academia. So universities and the federal government. So you may be familiar with OJJDP. They've got their model program guide. Most of those programs are on SAMHSA's guide as well, the National Institute of Justice. So these aren't programs that were created by someone that they're trying to promote or push their programs. What these are the national clearinghouses that the U.S. government has offered as a resource to service providers around the country to say, here's what you can choose from, and you have to select what meets your needs. And we're telling you, some of these programs have proven that they're effective, some of them have not, and so you may want to stay away from some of them that have not. We've evaluated them through research, through universities, and they've shown not to have promising practices. So they rate them according to varying levels.
So when we have a process in place to identify programs and that we use within the division and the department. We always look at the SAMHSA website to see, is that program evidence-based? If we're identifying something new, we consult with other agencies, but we do have a process in place. We look at the OJJDP website all the time. We're always looking for new programs. We have a current program now that we're doing that we're thinking that we need to think about switching and going to something else. So we're looking for, evidence-based practice and programs for that program to see if it's effective and appropriate. So, that's what we do in our division.
Christine?
Yeah.
I'm looking here at the this form, which we ask the task forces to submit about the recommendations that they're making, just to give a little bit of
Yeah,
background.
this one.
It says that DOC staff have requested a guide and listing of resources to help them select evidence-based programs for the youth and families they serve. Have you had a conversation with Mark about that in particular?
I mean, we're having discussions like about these kinds of things all the time.
Okay.
I mean, I didn't know it was going to be a formal request
Right.
today, I'll be honest with you.
Okay. I think as,
Sorry.
and I don't say this to sway commission members, but one of the things that comes to mind if we are requiring or making a recommendation that we require that they search and select evidence-based programming. That to me would hinder the state of Indiana's ability to test their own programming for effectiveness, to create another evidence-based type of treatment plan that DOC could use. I think it would hinder our ability to treat our own population in an evidence-based way that we
Yeah.
determine. That would be my concern about requiring it to be coming from certain sources rather than having some ability at least. Yes, we want evidence-based, but if we can be innovative in our own way to treat our own population, I don't think that we should be hindered from that exploration as a pilot program, for instance. That's just
Right.
my feeling.
I would agree.
And I'm not under the impression that this recommendation says we can't do that, because obviously we can. This is basically just listing resources for folks to go to if they're looking for something, if they don't have the ability to create. So I really wish that Mark were here so that he could answer some of these questions.
Yeah, I think I'm confused, and maybe that's where I'm,
DOC, the Children's Commission, I'm going to tell you, and you're not going to tell me, we want the judiciary, we want you to post on your website,
Right.
the Supreme Court website.
Yeah.
I don't understand it. So it's just a bunch of links, right?
Yeah.
To different requirements from different states and SAMHSA. Okay.
These are just samples. Aren't they just
Right.
samples of things that you can
But you
do?
can do that. I mean, DOC can do
Right.
that. I don't understand the request.
Madam
Mindy,
Chair.
can you give us any clarity on what the request is?
This, when we were asking task force members through our subcommittees and then through the general task force, this was one of the ideas that came up. And this came from Mark because he felt that it was something that was missing, that he didn't have access to. And I can't speak for the conversations that have gone on in DC, and I apologize because I'm not trying to, intrude on that at all. I'm just the person who's coming to deliver the message. But from our task force, when a member comes and says, I feel like this is something that would be useful and we should move forward with it, we, then vote on it and we decide, okay, that sounds like a good idea. But if it's something that the commission does not want to take on, or if this is something that just should be handled within DOC, that's not a problem, that's fine. It was just something that Mark felt would be useful to have available to staff.
I would assume, what I'm assuming is that because we've had so many discussions about the difference between evidence-based practice and what is appropriate, and if it's best practice, does that mean, is this program, if it's not evidence-based, does that mean it's not good? Should we not be doing it? So I know that we've had tons of discussions, so I'm sure that that's probably where this came from, because like I said, we're always looking to improve our services and improve our programs that we have in DOC, so I'm sure that that's probably where this came from.
Okay.
Madam Chair,
Yes.
Indiana has a very robust evidence-based decision-making group that is working on protocols that are going to be based on Hoosier values. I would be reluctant to put on any of our websites something that refers people to Florida when we've been working so hard with a lot of subject matter experts about how we think these kinds of programs should be developed in Indiana. To the extent that we are all embracing evidence-based practices as we encourage programs and the funding of programs, I think that's a good policy statement. But I would be reluctant to put on our website something that refers people out to other states when we've been working so hard on protocols and guidance in Indiana.
I would agree. Ms. Goodpaster, I think we'll go ahead and continue to hear the remainder of your presentation. I would like to table the approval of this particular recommendation to the next full commission meeting, give the task force time to kind of regroup, maybe talk with Christine or other various members of the commission. The executive committee then can come back and review those recommendations again so that we can get more clarity on exactly what we're doing.
Yeah.
Would that be okay?
That's fine.
And just
Yes,
clarification,
Mr. Moore.
on our website, we already
Right.
will refer people to NREP on the SAMHSA side. If you're looking for evidence-based mental health practices and interventions, here's a clearinghouse in SAMHSA that you can go to.
And it could
We don't
be-
recommend one over another, we don't fund one over another, it's just, here's a resource for you.
And it could be just an internal information distribution within DOC
Right.
on how to access that information rather than this step. I'm not saying it's right, wrong, or indifferent, just that we need more information about exactly what you're asking, and maybe also the commission could provide some direction back to the task force on what they would like to see, if anything.
Sure.
So,
And you know, again, I apologize. I guess I assumed that Mark was making a recommendation based on conversation that was recommended from DOC.
There's two
So,
other recommendations your subcommittee has.
Yeah.
Yeah.
Wanna go through those?
okay. So we have one other recommendation. That is the mandatory survey. So as the commission had done a couple of years ago, looking at where are the gaps in service providers for mental health and behavioral health services. And the caveat was we don't have enough data to really determine where those gaps in services are. And one of the reasons is because we're only relying on certain points of data, one being licensure. So a person renews their licensure, they may or may not be currently practicing. They could just be keeping their licensure, but they're a stay-at-home mom. They might be listing different addresses, so they list their home address, but that's not where they provide services. So we don't have enough data about, you know, who are the populations that they serve, what is their pay structure, do they accept insurance, do they accept Medicaid? So the idea that we crafted, along with Dr. Hannah Maxey from the Bowen Center, who does a lot of the health workforce study research, one of her ideas was to have a mandatory survey that other states do this, and she provided us the different statutes that come from different states, that asks just like 5 questions to try to get a better sense of the demographics of the people they serve, the geographic area of the places that they serve. And then I came up with the idea of asking them a question about, do they use telemedicine? So that we can get a better sense of where is telemedicine being used, and then actually do a further honing in on those professionals who are using telemedicine. What are their successes, what are their challenges, and how do we get it to be replicated through other parts of the state? So these are some of the potential survey questions that I already went through, and just any other relevant data. So we're not saying these have to be the questions, but this is the type of information that we would like to gather, and then we could make this a legislative ask, put this in statute so that it occurs during license renewal time, that professionals have to fill out the survey for us. So some of the benefits would be, you know, we can look at more comprehensive data. The Bowen Center has said they have the capacity, they have the resources to help us with this and help crunch all of the data. Then we can use this data to leverage some federal funding to create incentives for professionals in these health shortage areas. We're missing out on some of that critical funding. And we can already utilize other models that exist in other states once we look at which one seems to fit best with Indiana. Their recommendation was to look at Vermont statute because it's really simple. So the potential statute that would be affected would be 25-1, which has to do with the license renewal. But at the time of the writing of this recommendation, LSA hadn't determined whether they would amend it into an existing part of statute or whether they would create a new section for this piece. So that's still undetermined.
I have a couple of questions.
Sure.
And I'm not sure who, maybe Dr. Walthall or Mr. Hammond. Is this something MPH could do or is already has the capability to do?
They probably do have the capability to do it. I mean, they'd have to explore it with everything else they're doing for every other agency, and including
So
our office.
they might be able to do
I'll
it, although
defer
it
to
could be
Dr. Walker.
taxing on the resources. Is that the? Dr. Walthall?
Yeah, we'd have to find a funding stream for that.
Yeah.
To do that depth of research.
But is it necessary? It's necessary to find the, I mean, if it's a necessary data drop, or,
Right, if it's necessary for us to have it, then that's a separate question
Yeah,
during a budget year. Secondly, I'm sorry, Mr. Moore, is it possible, rather than us mandating a survey through legislation, to just have the certain questions that we need as part of the application process?
So it's already optional, and we do get some of those responses, but the idea would be to make it mandatory so that we get information, because I don't know how you guys are, but when you get surveys, you do them, you don't. But we would really like to see more capture of the data.
So are those questions currently on the application? It just says it's optional for you to answer them, or is it a separate optional survey?
That I can't answer. I don't know.
Because if we just embedded some of those questions that we need answers to for data collection as part of the application, rather than a mandatory survey or an optional survey after the fact, we may get that data collection without having to make it a mandatory survey in statute.
Well, the idea would be that the survey would be included with the application and with the renewal materials. It would not be something separate from
I get
the
that,
process.
but my point is that it would be a lot easier if you're trying to get the data collected to
Yeah.
just put
If
it
you don't
in
complete the
within
survey,
the
you don't-
application
your
than to
application's
mandate
correct.
Oh, I see what you're
legislatively a
saying.
survey.
The It application is. is not complete until you answer those
Right.
questions.
I see
Yeah.
what you're saying.
Who's,
Okay.
Dr. Walthall?
Yes, so the way that license renewals currently work, and it's really elegantly set up through PLA with the help of the Bowen Center. It was revised 2 years ago. So we've made it now through our full cycle of license renewal. There's half of licensed providers are renewed 1 year, and then the other half the second year. So we're through the full cycle. The new survey is very well done and gives us a much better idea of who, where, and what people are doing. It is optional, but it's done very nicely in that it's embedded in the process, and it's very easy to click through. So the return rate is actually quite good for that type of survey.
Do you know the return rate, or can we determine what the return rate
I can
currently
find
is?
out for the second round, I don't have that new one, but for the first round, it was upward of 60%. And because of the redesign, what it used to, just for geography, it used to allow you to put any address you want. So we knew where a bunch of physicians lived, but not where they practiced, which is not particularly helpful. So now it's a location of your practice, so we have a better idea of where people are and a little bit more granular what they do. Going from optional to mandatory, you'd have to, I think, talk with the Bowen Center and PLA about what we think the return on that process would be. If it's already fantastic, you may not gain any more, but again, the new design is quite good. So I don't think we need to build a new MPH process since we're already collecting this data. It's just making the process more robust and making sure we're capturing the entire health professions array.
I mean, the other question around mandate, are you really going to hold up a clinician's license because they didn't answer one of these geographic questions? I mean, that's kind of the trade-off you get.
Seems like we're making progress on our previous recommendation and then holding it up on the back end, which is not something I think we want to do in a shortage situation, but I agree with that comment.
I mean, did you know if your task force looked at the data that came from the 60% that are volunteer? Because that'd be a good starting point. Look to see what we have and then see if there's a gap.
See where the gaps might be.
Have you looked at that?
Yes. And so, and the Bowen Center did provide us with a lot of the information and data, but this recommendation came from them, so again, I'm not trying to step on any toes, but in our conversation with them, when we were trying to strategize, what are some ways that we can get better ideas so that we have, they feel like they need that data in order to access the funding that's available through the health professional shortage areas. And so they felt they didn't have the right or enough data to be able to go after those funds. So that's where this recommendation was born, and they felt, in their opinion, that the percentage of return was not great enough to really make that determination, so.
And I think what we could do, even if we decided not to go all the way to mandatory, is that there wasn't a lot of publicity around this really exciting change that was done. It just kind of happened organically. And so I think if there is some outreach or this is what we're doing with this information, and so the better the data, I mean,
physicians understand that. The better the data, the better the programming. I think there's some concerted efforts that we could make to encourage people to do that process. Again, if we can keep a survey at less than 3 minutes, the license renewal process is quick and easy, and then we get exactly what we need.
I would agree, and I would say that if anything would require, anything out of a budget year, we have to wait until next session anyway. So maybe it's a matter of increasing the knowledge toward updating applications for practitioners that this is important.
Right. I suspect that most don't know what happens with that information after it's collected, and so if we could give the mission and the vision of what this is about, I suspect people would buy in and get tracked toward more meaningful information.
Then when we come back again to revisit this issue, if we're able to make those changes legislatively to the licensure issues, that may also help with the shortages that we see, and maybe we'll get an even higher participation rate at that point. And you're not asking for us to make this recommendation today?
No.
No,
If
okay,
if it's
all
the
right.
will of the commission, no.
Okay. Any other commentary on?
I just like the embedded of these questions in the application.
Dr. Walpole, would that be acceptable in terms of a practitioner's perspective of having to go through that process?
Right. Again, that's how it's designed now.
Okay,
So
but
that
it's
wouldn't
just
be-
that those questions are optional. I don't think if we do make it part of an application process, I'm not sure that we would have to legislate that. I think that's just something you guys could do within the agencies, so, okay.
I just would like to a bonus center, since they're recommending this, talk to the licensing board and see. what
They all work together
Yeah.
very
Yeah.
beautifully
Right.
already.
Go there first.
Go there first, yeah. Great.
I would like to request, though, respectfully, that if we could include questions about the use of telemedicine, because I feel like we don't have that data. Anecdotally, I heard from a service provider in southern Indiana. They were contracting services through Bloomington Meadows, and then because the person who ran that program got promoted, they couldn't find anyone to fill her position, the program stopped. And it was a very useful asset for them to be able to have those services for their youth. So I would just like to further study the use and see how we can make recommendations to expand it.
And the telemedicine inclusion of that survey question was recommended by the Bowen Center as well?
No, that was my recommendation.
That was your recommendation?
Yes.
Okay, all right.
That was my idea.
Just as a need for the state,
Yeah.
as part of the task force?
Yeah.
Okay. Is there any input from the commission on that piece?
I think every time the survey goes out, it needs to be looked at to make sure that the questions that are on it are relevant for what we're trying
What
to
you're
do.
trying to
And so
collect, yeah.
as we add one around telemedicine, then we take off something that was a priority before that we've addressed and checked the box. And that, again, keeps the survey process fresh and relevant for providers as they do it. So I agree. We don't have our arms around the uptake of telehealth throughout the state. So that would be a very reasonable recommendation.
Okay, great. Thank you. Thank you. Is there anything else? Any other questions for Ms. Goodpaster? All right, thank you very much.
Thank you.
Okay. Moving on. Martha Allen, strategic priority on child and safety services.
Good morning. Thank you so much for inviting me to present to you today. I've been asked to share an update on infant mortality and specifically the impact that opioids have had on the newborns born in Indiana and what we are doing to address that epidemic. Please feel free to ask me questions as we move through. You have all this information in your packet. I want to start out by just defining what infant mortality rate is, assuming that no one in the room knows this. I want to give a basis of that foundation. It's a death of a baby born before his or her first birthday. So the infant mortality rate is established based on the number of live births per 1,000, or the deaths that occur per 1,000 live births. It is frequently said that it's the #1 indicator of health in the world. If you can take care of babies within any community, you're going to take care of the rest of the population. So that's the reason why we focus on infant mortality. So within Indiana, our rate is higher than that, both of the national rate and the Healthy People 2020 goal. The 2015 rate of infant mortality in Indiana is 7.3. You may ask, why are we looking at 2015 when it's 2017? A baby born on December 31st of 16 has until this December to live to its first birthday. So we will not know the infant mortality rate of 2016 until the first few weeks of 2018. So yes, this appears to be retrospective, but in reality, it's our most recent data. In Indiana, we have a larger problem than just our infant mortality rate. There continue to be disparities within our populations. The Black infants die at a 2.1 times higher rate than the white infants in Indiana. A lot of the information I'm going to share outline Black and white infants. That's because those are the two largest categories of populations within Indiana. We can break it down to Hispanic and other groups, so if you're interested in any other categories, feel free to reach out to me and we will get you that information. So to put a picture around what that means for Indiana, in 2015, 613 Hoosier babies died before their first birthday. That's 50 every month, 12 every week. If you look at the 5-year trend, that could fill nearly 42 school buses to capacity. So we are not talking about a small number here. So when you look at the Indiana infant mortality rate compared to the U.S. and the Healthy People 2020 goal, you can see at the far right bottom that we continue to be higher than both. The U.S. did drop below the Healthy People 2020 goal in 2014, so there's some exciting trends at the national level, but in Indiana we continue to increase, and I will share more details moving forward. As I mentioned, there's a huge disparity between white and Black infants in Indiana. The Black infant mortality in 2015 was 13.2. compared to the white infant mortality of 6.4. So we are seeing a downward trend in Black infant mortality rate. However, because we had a slight uptick in the white infant mortality rate, our overall rate did increase. It's often said that health is more dependent on your zip code than your genetic code, and that's true in Indiana. If you look across the state, the aggregated data of 2011 to 15 showed that we have a wide span of infant mortality rates. And the reason why the Midwestern region is circled is that's the highest rate that we had for that period of time. And if you look at the resources, particularly the hospitals in that area, it's a very underserved community, and we're trying to put more resources in that area to support that. Just most recently, through our Safety Pin grant, which is a state-provided funds to address infant mortality, we were able to award a group to work in that area. So we're excited to see that, the opportunity of that coming down in the future. The reason why these numbers are often aggregated is that when you get down to the region, county, and zip code level, the data becomes very unstable. So we like to look at it in aggregate. So if you break it down by zip code, it's even more alarming. You can see that there's a wide variety of infant mortality rates. So reminding you that the rate is 7.3 for Indiana. Bartholomew County is 10.7. So we have some counties in the green that are doing very well, and some in the red that are doing worse than the Indiana rate. When you break it down by zip code, it's even more alarming. Lake County is 25.2 for their Black infants.
That's 1 in 4 babies die.
And then Tippecanoe is 38. So when you look at opportunities, you really have to get to the community level. Now, I will remind you that a lot of this data is unstable because of the number of deaths, but that doesn't sway us from trying to impact those areas that need the most resources.
Not thriving, not going to the doctor.
So looking at Indiana mothers overall, and there's a lot of statistics on this slide, but what I'd like to point out in particular is that we have about 43% of our mothers that are reporting are on Medicaid. Now, this information is pulled from the birth certificate, We often say that 50 to 60% of our deliveries are receiving Medicaid, but the mothers may not understand what Medicaid is when they're answering this question. So they are reporting 43%. Down at the bottom are the most concerning pieces, that the average prenatal care visit begins at the third month, and then the number of visits are lower than we want it to be. We need early prenatal care and often throughout pregnancies. So when you look at our priorities to address infant mortality, it's helpful to look at the health factors related to that. Indiana, if one of our main priorities is to address obesity, and a woman that is obese has a 25% higher chance of delivering a preterm infant, which leads to infant mortality. And Indiana overall is the 15th most obese state. Smoking rates within pregnant women, those that are saying that they are on Medicaid, 24.7% of those mothers are reporting smoking during their pregnancy. So a lot of our initiatives to improve the health of mothers in Indiana are relating to smoking cessation. I mentioned prenatal care. We are only at 69.3% of mothers that receive any type of care within their first trimester. That includes one visit or more. And then our unsafe sleep practices are higher than the national rates at 13.5. And I'll break those down a little bit more here in a moment. So when you look at our overall infant mortality rate, I mentioned the 613 babies that died before their first birthday in that year. The chart on the left breaks it down by cause. So 48% of those were related to perinatal risks. That includes things that are impacted by mother's health during her pregnancy, before, during, and after. Congenital malformations remain high. 13.5% of SUIDs, and SUIDs is a category that is sudden unexpected infant deaths. You may have heard of SIDS. SIDS is a type of SUIDs. So SUIDs is the larger category that encompasses any of those sleep-related deaths. And then on the right-hand side, it takes the 7.3% rate and breaks that rate down by the same categories. So if you're looking at the overall rate, 3.5 of that 7.3 is perinatal risks. So if we can improve the health of mother during her pregnancy, we have a great opportunity to improve the infant mortality rate.
If I can just ask a quick clarifying question, and
Sure.
you may address this later on in the presentation. So when we talk about the distribution by cause, we have it listed under mother's health and SUIDs, congenital malformations. Are you able to further define that into subcategories such as drug use by the mother? That could be under mother's health, that could be under a SUIDs issue, that could also fall under congenital malformations. So I would be curious if you're tracking, or if you're able to track subcategories, and I have talked to the Department of Child Services about this recently in their reporting, for instance, of their child fatalities. Their report mentions that there were relatable issues of marijuana use by the parents and drug use by the parents, but the cause is listed as sudden infant death syndrome or accidental drowning, even though a contributing factor to that is drug use. I think it would be helpful for the Commission, if we aren't tracking that, to find a way to identify if it is the perinatal risk, are drugs a factor in that risk, et cetera.
Very well said. I will tell you that that's one of the reasons I'm asked to present today, is that we were legislated to begin studying the impact on newborns. In Indiana, there is not a requirement for universal drug screening, so we don't know how many mothers are exposed to drugs during their pregnancy, nor do we know how many babies are exposed to drugs. So that is something that we are hopeful to achieve in the future. Right now, it's all that we know are self-reported.
Well, or if it's an infant born with a drug-affected issue, then
Correct.
that might get reported to Child Services.
Correct.
And then that would be tracked, but there would be some that we might miss.
Yes.
Who may not be outwardly showing signs of a drug affection at the time of birth.
Right, right. Yeah, I think we have several opportunities there. I'm going to share neonatal abstinence syndrome in a moment, which is a diagnosis given to those drug-exposed newborns that meet certain criteria. That is currently a required diagnosis in our Indiana Birth Problems Defect Registry. However, it's not culturally been consistently applied. So we need to enforce or encourage that diagnosis to be reported more in the future. And I think our work on addressing drug-exposed newborns is going to help change that culture.
The other thing I would add too, and this may be in the weeds, but having worked for child services before, drug-affected babies are also affected by methadone.
Absolutely.
In many cases, and those effects I've seen worse than, street drugs.
Right.
So I don't want us to neglect that now that especially Medicaid is paying for methadone. I don't want to neglect that as part of our overall analysis as part of that neonatal abstinence syndrome.
Yes, and methadone, you will see in the later charts I provide about the drug exposure study that we're doing. Methadone is one of the chemicals that we're measuring.
Okay, good.
And we want that number to go up because more women are receiving treatment. So it sounds contraindicated that you would want that number to go up, but if a mother is taking drugs during her pregnancy, we want her to seek treatment. So we are measuring that, and we'll continue to support initiatives to help fill in that gap.
And while we're doing that, I think it's incumbent upon us to look at, and Dr. Walthall, I'd be interested to get your input on this at some point, but universal recommendations for treatment plans within those methadone clinics for pregnant women. I had certainly witnessed, as I mentioned, drug-affected babies where the mother had take-home doses, the boyfriend had take-home doses, and there was not a lot of monitoring going on of what she was taking, and that infant was in the NICU for 6 months on the highest doses of... They get to take them home rather than take them at the clinic.
Methadone?
The methadone. And so she was taking more than what she was prescribed, if you will, by the clinic, and there was no real monitoring of that for a pregnant woman. Now, that was several years ago. There may be additional
We've come a long way.
Yes, we've come a very long way.
That was a long time ago, so that was several years ago. But I do want to, that is one of my concerns as we expand the use of methadone. We'd rather have them being in treatment than not. But I want to make sure that we are adequately treating those, particularly those pregnant women.
Yeah, we absolutely can have that discussion and talk about how the new methadone policy is bundled with services. It really reflects best practice for moms and during pregnancy.
I'm sorry, go ahead. Say that one more time, please, Dr. Walthall.
So our new methadone policy for Indiana Medicaid went live September 1st, and it is a bundled service so that methadone is not paid for as a single standalone medicine, but is bundled within best practice treatment. And the oversight and regulation that the Division of Mental Health and Addiction does is truly extraordinary.
Good. Yes, Senator Breaux.
And while we're tracking this, I would like very much to see a breakdown of cost. You say quite a few of these women are giving birth under Medicaid. I would like to understand what is the Medicaid cost for these births versus a private pay. And I would also like to know how many of these births are unplanned as opposed to family planning practices in place that result in a tragic death before the first year. So I would really like to understand how much is it costing on Medicaid versus private pay, and how many of these births, and if we can get an age range of the mothers of these births. I think that would be very helpful. I don't know if that's something that you have further on.
Senator Breaux, I think Dr. Walthall has an answer for you.
We have all that data. So we're approximately for last year, 48,000.
Can you give us a presentation?
Sure. 48,000 of Indiana's 80,000 births were covered under an Indiana Medicaid program. It was one of the reasons that we, in our HIP 2.0 renewal waiver that is currently pending but almost approved, has expanded pregnancy services as part of that to make sure that we're providing the best quality at the best cost
So what is that?
for pregnancy coverage.
What does that equate to in terms of
A little bit more than
cost?
50% of
50%
the births.
Medicaid budget?
No, 50% of our Indiana births are covered by Indiana Medicaid.
48,000 births out of 80, what does that equate to in terms of dollars?
So I can
and cents?
break that all down for you by,
Yeah,
there are
it'd be
multiple
great to get
different,
the presentation from Dr. Walker.
happy to do it.
Okay, great. To your point on unplanned pregnancy, there was recently research done that showed that approximately 80% of mothers that are taking opioids have unplanned pregnancies. So it is a higher risk factor when opioids are involved, and we speculate that that's one of the reasons why Indiana's infant mortality rate continues to go up, and despite all our efforts of best practices, because the opioid epidemic is impacting everything that we do in public health.
So is there any kind of a, I don't know how to say this other than to say this, are there any kind of birth control practices that are recommended to mothers who give birth to neonatal abstinence babies so that we don't, is there a continuation? Once one birth has happened under opioids, if they don't get treatment, do we see subsequent births, or is there some kind of practice that would prevent further births from occurring?
Currently, we're focusing on all deliveries across Indiana to offer what we call LARCs, long-acting reversible contraceptives. You may have understood those historically as IUDs, where those can be placed when a mother chooses to not get pregnant in the next 2 years. So that's a conversation that providers are having with all of their mothers. There are several hospitals that are even providing those at the time of delivery if a mother chooses not to have a future pregnancy or in the next 2 years, because birth spacing can impact the health of mom and baby, certainly her future pregnancies.
And not all hospitals are doing that.
Not all hospitals. That's a little challenging conversation in some of our Catholic hospitals. And then some of the hospitals are still coming on board with hardwiring that practice.
But I think all of that needs to be a part of this conversation.
Absolutely, absolutely. We have a large group of 300 individuals across the state that make up our Indiana Perinatal Quality Improvement Collaborative, IPQIC, and there's a task force specifically looking at each one of those factors: cost, long-term birth spacing, long-acting reversing contraceptives, all of those pieces to improve the practice in Indiana.
Well, I'd like to participate in that if that's possible.
That would be fabulous. Thank you. Yes.
Okay, I think we're ready.
All right. Wonderful. So SUIDs, I had mentioned, is sudden unexpected infant deaths. This breaks it down by the cause in Indiana. The one thing that I want to point out here is the second to the highest line, and I know your document is black and white, but on the screen, the teal line is going up. Those are suffocation deaths. We know in Indiana there's an opportunity to teach what we call the ABCs, alone on your back in a crib, so that we have safer...
And sober.
I'm sorry?
And sober.
And sober, yes, we could add that as well. So you can see the suffocation deaths are going up. Part of that, I think, is because we are doing better coding. So you can see that the SIDS, the line just above that, is coming down. It's because we are improving our coding, but we also don't want to be complacent and think that there is not an increase in suffocation deaths, because we believe that there is, especially in certain regions or populations across the state.
And again, I assume you're tracking when those accidental suffocations are related to a substance use issue.
Absolutely. We have FEMRs, fetal infant mortality reviews, that look into all the infant deaths. And they're not in every county, but we're acquiring more. And in one recent FEMR group, there were 6 deaths within a period of time, and 4 of those had opioids in the home. So we certainly understand that opioids make that more challenging.
Thank you.
Looking at low birth weight of babies, you can see that there's a large disparity between the black and white infants born in Indiana. The percentage of preterm births in Indiana before 37 weeks, we continue to remain higher than we want to be, and there's that disparity between black and white infants. Women receiving prenatal care in the first trimester, I had mentioned that our rate is not where we want it to be. The Indiana rate is 69.3. Our white mothers are acquiring more prenatal care in that first trimester compared to our black mothers, so we have work to do in both populations. The number of women smoking during their pregnancy. You can see a downward trend, but we don't want to celebrate that because, quite frankly, so is the U.S. I think there's a downward trend in a lot of populations in smoking overall, but our smoking among pregnant mothers, this is the overall rate, the 14.3. But if you'll recall on a previous slide, I had mentioned that mothers on Medicaid are at 27.4. So it's really important us to break down by population or payer mix so that we know what the actual rate is. And then the teen mothers. Indiana rate, again, is going down. The top two lines are Indiana, the bottom lines are the U.S. And I will again use the same analogy with smoking. We don't want to be complacent about our teen mothers thinking that we are decreasing our rate, because we are doing it at exactly the same trend as the U.S. So we still have a lot of work to do with our teenage mothers.
Can you tell what that number is in terms of actual numbers? It's 26.0. What does that equate to in terms of the actual number of teens?
That's a birth rate of mothers, so I don't have that number, but I can get it to you. And then breastfeeding is a very important priority within maternal health. And we are seeing an upward trend in all categories, but you can see there's still a disparity between black and white mothers. 68.5% of our black mothers are breastfeeding at the time of discharge. We like to further break that down by the long-term practice of breastfeeding. So we try to coach mothers that we would like them to be exclusive with breastfeeding at least 6 months, ideally 1 year. You can see on the far left, ever breastfed. We are at 76.1 compared to the U.S. at 81.1. So we're doing well if ever breastfed. But when you break down the categories of how long they're breastfeeding and if it's exclusive, we have a lot of work to do. So I mentioned IPQUIC earlier. There are a lot of initiatives that IPQUIC is working on over the years. We work to decrease the number of early elective deliveries because we want to avoid those preterm births. 17P is a progesterone that's given to mothers that have a history of losses, and that helps prevent prematurity or losses or early deliveries. So we are working even this year to help improve that toolkit and improve that practice across the state. I'm going to talk a little bit more about neonatal abstinence syndrome in a moment, but we have 26 of our 89 delivering hospitals working on our prevalence study, and then I mentioned a few others already this morning. One exciting thing that I'd like to mention before we go into the NAS information is that we literally this week went live with our pregnancy mobile app. So you'll see down at the bottom that it's not going to be launched until our Labor of Love Summit on Immortality next Wednesday. However, Monday it became live in the Apple and Google stores. So if you go in and Google or place in either one of those stores, Live, L-I-V, pregnancy. Now in the future when we have millions of people on this app, you'll only be able to put in Live, but for now you have to use both categories, Live, pregnancy. You will have the ability to download this free app, and it's intended to improve the health of mothers and children, specifically in Indiana. It has resources and a map where women can find the closest car seat station, the closest WIC office, where they can find a pediatrician that accepts Medicaid. And then we built in a lot of things that just establish the best practices for women and children in Indiana. So we are hopeful that that will improve the health of women. This was a legislated act that we were to develop this app, and it has truly been one of the most exciting things that I've worked on in my career. So Liv, L-I-V, is the character within the app that helps you navigate through it. She is a person, but it also indicates...
Senator Houchin is on it as we speak.
Oh, there you go. Wonderful. Liv, pregnancy. And so Liv is the character, but we also used her name as a play on words because the goal is to help infants live past their first birthday. So we're hoping this will be fun and interactive. Our target audience when developing it was a 15-year-old mother or 15-year-old woman that just found out she was pregnant and doesn't want to tell anyone and needs resources at her fingertips.
We need to, with regard to probation, Susan, we need to go to
I
a
will
lot of juvenile pregnant
share that.
gal
Yeah.
probation, and also DCS. You build it to come.
Fabulous.
But we need to have some training with next probation. They're meeting here soon.
Probation Officer Advisory Board, we just met a couple of weeks
When is your
ago.
when is the yearly probation officer meeting?
It's in May.
Isn't there another one coming up? No.
There's Popeye one that was in September. We have IACAC coming up.
If there are any groups that I can get in front of to share this information, please feel free to reach out to me. We are developing in mass quantity, and by mass I mean probably hundreds of thousands of business cards that will have this information. You turn it over, it's got the QR code on the back, you can zap it with your smartphone, you're on the app. So we are going to get those out in mass quantities to, first of all, every delivering mother in Indiana, all provider offices, WIC offices, local health departments, DCS, anybody that has an
Remember probation. probation as well. Probation
Yes.
has a lot of pregnant mothers under supervision.
Absolutely. So we will get those promotional items out as soon as it's launched next week, but we truly want to get this in the hand of every mother in Indiana.
And if you're LIV or LIV?
LIV, but you have to put pregnancy behind it because
I come up with a $5.99 one when I do that.
it should have a face of a character on it.
LIV pregnancy.
Yeah, LIV pregnancy.
And if I could, I'm looking at your app, I'm wondering if you have the ability for pregnant women to set goals. I'm thinking of, you know, I need to get to X number of prenatal visits, and then they can track their progress, or I didn't smoke this week, or, you know, any of those type of health goals related to their pregnancy. Is that part of the app?
Absolutely, and that's been one of the fun things of developing this is that we are building in badges. So women, it's a gaming feature. You know, if you fill out the profile, you get badges. If you attend prenatal care,
or other of the
yeah,
health
we want it
tracking.
to be fun and interactive. We hope to eventually have partners that we can even do drawings, so when women achieve these badges, it's not just a picture on a screen that they get, but there can be rewards or incentives behind that. So that's a next step.
Great.
But it does include best practices, not only those resources, but articles, information. We can push out alerts. So if we have a Zika warning, if we have a car seat recall, we can put those alerts on there so that all of those families are getting that information at a moment's notice.
Fabulous.
I don't want to be
But
too
certainly as
touchy-feely here, but this outcome is truly what happens when our branches all work together. This was the product of a 2014 legislative agenda with the safety pin bill, and to see it now come to fruition with all of us working together around infant mortality is truly extraordinary.
We're going to have a communication report. What we need to do, we have a communication plan that we're doing with the Children's Commission. We need to pull this into the communication plan.
Excellent.
We also have the app that was developed by this commission with information sharing. So we're going to be hearing in a little bit from our community. So we need to piggyback on using all our branches, communications departments to get this out. I mean, we really could work it in the judiciary, we could work it into dispositional orders with regard to, you know, you come in, you work with the probation officer, and you kind of go through what's been done, and then we've got the ability to do incentives and sanctions, not the sanctions on that, but these badges could have a monetary.
Absolutely, absolutely. The sky's the limit. So certainly as you and others get into the app, if there's any future things that you would like to have included, feel free to reach out to me because we already have a long list of things that we want to do next within the app.
If there's the ability to embed ads into these, it might be helpful to have an ad for Live in the Children's Commission's app and vice versa, so that anybody getting that could be informed of the other apps that we have available through the state.
And it will be listed on IN.gov as one of the state apps. We tried to be very intentional of not making this look like a government app, because if you think about that 15-year-old that doesn't want her grandmother to know she's pregnant, she certainly doesn't want the government to know she's pregnant. So ISDH logo is in the app, but you have to try really hard to find it. We will have it posted on IN.gov though.
Great, thanks. Anyone else? Please continue.
Okay, I had mentioned earlier that we were also legislated to study perinatal substance use within Indiana. We were provided permissive language in legislation back in 2014 and 15 that directed us at the ISDH to conduct a pilot study to, first of all, define and set standards for NAS, and I'm going to do that here for you in a moment. So in 2016, we initially had 4 hospitals that volunteered to be part of this study. In 2017, we said, great, we have some results, let's increase it. We were hoping to get 5, we got 26 of our 89 hospitals. And so by the end of the year, we're hopeful that those 26 will be adopting our standards and protocols. And then in 2018, our objective is to spread that across all of our hospitals.
Is this mandatory drug screening on all infants in the pilots?
It's a process for determining if drug screening needs to occur. Our ultimate goal is that it will demonstrate a prevalence that will encourage universal drug screening for all moms and newborns. So it's not, the information I'm going to show you is not all newborns, it's those tested. So if you look at this map, the dots on there show the hospitals across the state, and I like to say that if you took a paintbrush and splattered it against the wall, you'd get this map. We were very intentional with the first 4 hospitals, that they were large, small, rural, and urban, but now we've got representatives from across the state. And the reason why there's only 18 versus 26 listed on the year is these are the 18 that are currently on board with adding to our database for the prevalency rate, but there are more hospitals that are adopting our practices.
So what, they have to have some indication of drug use, there's drug screening, it's not done, do you know what percentage of the children are doing? I mean, I'm hearing nationally 15 to 25% are all children are drug exposed. Is that the number?
Yes, that's what I'm going to show you here in a moment. It is that alarming. We initially, the reason why this was a legislative directive is in 2014, the legislators said, what is your rate? Should we do universal drug screening? And they asked the Department of Health what our rate of drug-exposed newborns is, and we said, we don't know. So they directed us to go out there and study it, and that's the reason why we've gone down this path. Hospitals told us historically that 1 in 5 mothers are exposed to drugs when they come in to deliver, and that is the number that we are seeing in our prevalency study. So just as a basis so everybody understands what neonatal abstinence syndrome is, it is a diagnosis. So we often say babies are born with this. That's not the case. It is a diagnosis provided to a baby that is born exposed to drugs. So not all babies that are exposed to the drugs I'm going to show you are diagnosed with this NAS. However, it is the diagnosis that we have that will be able to trend going forward. And it's most frequently a result of opioids, although there are others, like we mentioned methadone earlier, that do show up positive in these tests. And we've just recently added alcohol to our panel. So at a national level, the rate of NAS has just exploded. I don't think there's any other way you can put it. The incident from 2000 to 2009 per 1,000 births went from 1.2 to 3.4, so nearly tripled. The maternal opioid use has increased dramatically from 1.19 to 5.63. And then the cost for infants diagnosed with NAS has just skyrocketed because these babies often are in the NICU going through withdrawal symptoms, and certainly beyond just the NICU stay, there are lifelong implications to being exposed to these drugs.
And did you give us an indicator of how many of the affected of the NAS might be Medicaid related? Have you given us a number on that?
We have not broken that down. Because our population, our sample size is very small, we have looked at it as a state number, but certainly as we bring more hospitals on board, that's one of the factors we're going to look at.
I know that East Hospital looked at that. They were one of the 4 original pilots, and nationally that level was like 78%, and we were at 79%, so it was actually higher than the national rate.
At that one facility?
The one
facility.
Okay.
The numbers are just too small to make statistical inference based
Right.
on.
But you are anticipating, as more people come on board, that you might begin to break that down as well?
Absolutely. Yes, absolutely.
May I ask Dr. Walther?
Yes, go ahead.
So Dr. Walther, when you say that, and I don't have the numbers, but when you say the number of births on Medicaid, does that include these costs as well when you calculate the cost, overall cost of Medicaid births? It does include neonatal. Okay.
It does.
So what our substance use data collection consists of is that we track the number of cord samples that are sent. The reason why we do cords is because that is it gives you the most reliable information versus urine drug screen or testing the baby's blood, because some of those chemicals that are found in the cord may not show up in the other tests. We do those various tests as well, but our study is focusing specifically on cord samples. The number of cord samples that are positive for drug exposure, the substances identified, and again, we're reporting that as a state rate at this point in time. And then the data collection hopefully will help determine our prevalency rates overall.
What panel do you look for on your substances? Do you select ahead of time, or do you just look for everything that's there?
No, it's a panel of 13 different chemicals, and I'll show you that breakdown in a moment, but it's a standard chemical. We have even used a standard lab, USDTL, because we wanted to have consistent information that we could trend over time. So there are more hospitals that are using different labs, but for our study we are using one panel, one lab, so that we can trend over time. So what we found from our study is that the drug of choice varies by location, much like our infant mortality rate. Any comorbidities make this just much more complicated. That there's a lack of providers, even that we've heard already today, both for mothers and babies. That there's an interruption in care when a referral is made. Obstetricians went into practice to deliver babies. So it is very challenging to find an obstetrician that also treats opioid addiction. That number is growing, but it's a very challenging conversation because that's not why they went into practice. So often an obstetrician will refer to someone that is a drug treatment program, but during pregnancy, the drug treatment programs don't want to address pregnant women. So it's kind of a catch-22 that we're addressing, but our numbers of providers are going up across the state. And then we need to change the culture of those providers. So it's not a gotcha environment. We aren't going to legalize this and make it a scenario where we stigmatize it, but we're actually trying to do the opposite and just bring awareness to this so that we can treat these mothers and babies. So here's the big question, what are our rates? You can see that the fourth bar, cannabinoids, marijuana, is our highest rate. It's very surprising in Indiana. I would expect that in Colorado, where it's legal. I didn't expect to see that in Indiana. The second highest is opioids. So during the 9 months that we tested this year, and we were very intentional to just list this year because we have increased our hospital sample size. So the rate currently is 16% of cords tested are showing positive for opioids, related to a 10.8% at a national level. So almost twice the rate of the national level. Again, I will say this is of cords tested, this is not all births in Indiana, but until we have universal drug screening, this is the most accurate information that we have.
Sometimes.
And then you can see on the far left, we have added alcohol, and then there's other medications, methadone's on there. I mentioned earlier we want that number to go up. It is going up. The first time we sampled, while our sample size was smaller, it was, I believe, at 0.6, and we are currently at 2.2. So knowing that we have these drug-exposed newborns, we want the rate of the medications to help treat the mother to go up.
So what is the total number of all drugs and substances of the sample cords? What percentage is it?
The majority of the cords tested showed one chemical, so any one of these. There are some that had 2 or 3 chemicals, so we can break that down by drug, but we are still looking at it as an overall aggregate for the state.
And that would be what percentage? Just say unique children that were tested, even though they may have multiple drugs in their system. What was the percentage of the amount in pilot programs that tested positive for any
No,
drugs?
but
It's still trending at what the hospitals have told us. About 1 in 5 mothers, 20% are showing an exposure of some type of drug during their pregnancy. Or I should say at the time of delivery, because our current protocol that we've established is to test mothers when they arrive for delivery. Best practice is the testing of mothers during their pregnancy throughout their prenatal care. It's harder to dictate practice within a private physician office, especially if they're not affiliated with a hospital, but we are hopeful that we can set this as a standard practice once the mothers come to deliver at the hospital.
You may have already stated this. Is this a random sampling, or is this once the hospital has some suspicion of use?
No, there's an actual algorithm for what mothers are cords are tested. Yes, so it starts out with asking the mother if she was exposed to drugs during her pregnancy. There may or may not be a drug test or urine drugs done on mom, and then it's based on a diagnosis of baby following delivery.
It's not just random, though. It
It
is
is not.
actually targeted testing of people that we feel are at risk based on
Yes.
prior drug screens, prior usage, potentially coming in with no prenatal care and delivering signs or symptoms with the baby afterwards.
Yes.
So it isn't just a random sampling of all of our deliveries. So we expect this number actually to be higher, is what
Yes.
Martha's trying to allude to.
We believe this is an undersampling because it's only of those mothers that either reported on admission, baby shows symptoms before discharge. If mom says, I have not been using drugs, baby's discharged at 48 hours and then begins showing symptoms at 72 hours, we don't capture that baby. Now, we are working on programs to help support doing home visiting within the home so that we can address those babies, but the rate is higher than what we are able to demonstrate.
Of these 1 and 5, and you said that they averaged 1, do you know what the breakdown is for folks that have more than one substance in their core?
Yes, I believe it was that about 85% of the drugs, or the cords tested, showed one substance. The next category was 2. We did have one sample that had 4.
So what percent had 2?
I believe it was at 16%.
Okay, so it's under the 85.
Yes, much lower, yes.
And the prominent drug is cannabinoid?
It is, yes.
Marijuana?
Yes.
This may be a subject for a different time, so forgive me, but are there any concerns about what's happening in Washington as to how that will impact programs down the line, or funding of future programs and that sort of thing? Are you seeing any concerns about that?
Specifically related to opioids, I haven't seen any concerns, but certainly as they're looking at allocating resources to maternal child health and other initiatives, it could impact this. This study itself is completely based on paying for the lab test, so none of the funds that are allocated to ISDH go towards this project, other than the fact that we're coordinating it. But the expense right now is completely on the private payer or insurance side, because it's a lab test.
Okay.
And then the last thing that I wanted to show is the breakdown of some other factors that were trending. So of the cords tested, that reflects almost 12,000 births, and we have about 80 to 84,000 deliveries in Indiana. The number of cords tested is just under 1,900, and then the number positive, 773. So the most alarming thing on here is the very top one, the number of NAS diagnoses. We need to do a better job of diagnosing these infants. We also need to ensure that every infant that is drug exposed gets the support they need. And the last thing I wanted to show you is just to wrap this back around to infant mortality rate. These socks demonstrate, every pair of socks demonstrates one baby that died before its first birthday. So there are 613 pair of socks on these. We take these to community events so that we can give it a visual and really help in the community understand that we need to work on improving the health of moms and babies. Any other questions?
Just a comment. One of the pilot projects that was approved by the General Assembly last year was to fund a health system to intervene with pregnant moms early with addiction treatment, to support the mom and the child through potential NAS, and then to provide wraparound services for that mom for up to 2 years. And we just recently awarded that to Community Health Network, and so they will begin that work. They're already doing that work. This will help provide some funding for that. So women in that health system who come in and early identified to be pregnant and with an opiate use disorder or an addiction will get treatment early, hopefully to lower the number of NAS cases that they are seeing, the number of addicted babies that they are delivering, and then supporting that mom and family with wraparound services after the birth. So it's a very well-designed program at Community, and we think it can have great benefits. So that's just one of the efforts around addressing some of this pretty scary news. Yeah.
Excellent.
Thank you.
Yes, thank you very much.
Thank you.
We are going to take a 5-minute break just to grab lunch, and then we're going to keep working because we're pushing well into our deadline. So
I think we can deal with some of this. Before we had the forum, we dealt with some of the registration. Really, the folks maybe after lunch.
So you may not have it. I'll share mine with you.
I hope to be done by
could you close that door whenever you exit? Just close the door when you, we want you to come back, but just close the door for us.
Don't let the door hit you and you get out.
Poor Julia, she's like, I am so.
Thank you.
Thanks, everybody. My name is Patrick McAllister. I'm the Policy Director for the Department of Education. I led the policy planning process around our Every Student Succeeds Act plan. So I'm going to go through a few elements of ESSA and talk a little bit about how it coincides and works with the goals of the Commission. But just for some brief context, the Every Student Succeeds Act is a reauthorization of the Elementary and Secondary Education Act that happened back in the 60s. It is a replacement to a more recent act, No Child Left Behind. How many of you heard of No Child Left Behind before? Most people laugh when I say that. So it was signed into law in 2015. It was bipartisan. It was passed by a Republican Congress and signed into law by a Democratic president. And we were to write a plan in response to the act. And so Indiana submitted its ESSA plan to the U.S. Department of Education in September. This came after 9 months of planning and development and stakeholder engagement and a lot of community conversations to arrive at the plan that we submitted. And so I'm going to talk briefly about a few elements of the plan and how they overlap with the Commission's goals. So in the plan, we had to set some long-term academic goals for the state. These were federally mandated goals, and they had very clear definitions of what we had to achieve in those goals. The other important thing to note is that the goals were not tied to any accountability or funding mechanisms. They were goals that the state had to set. But those goals do look at student subgroups pretty heavily, which I think is of interest, especially when we're thinking about underserved students. We also had to set some parameters around our federal school accountability measurements. There were new elements that we had to include, and so we went through a process to develop that. School improvement is also of interest. These are supports for schools that are struggling and how we identify those schools and how they relate to student subgroups. And then we also have our Supporting All Students section, which includes a new funding stream that schools can access that is focused on the whole child. And it's a set amount of resources that are set aside. I do have our expert in this area who is here in attendance, and she'll be able to answer detailed questions if you have interest in that funding stream. So under ESSA, the state was required to set long-term goals under academic achievement, which we in our state call proficiency. We also had to set goals around our graduation rate. The new one that we have to set goals around for our English language learners, a growth to proficiency goal, which basically says how far along is an English language learner on their path to proficiency, and we had to set some measurements around that. The academic achievement measurement is based on our state test, which is currently ISTEP, but we'll be transitioning to iLearn. The English language growth to proficiency test is around our WIDA test, which is a test that every English language learner takes. Our graduation rate is based on our 4-year cohort adjusted graduation rate. Again, these goals are not tied to school accountability or funding. They are goals that the state needed to set. I want to emphasize that again. The reason these goals are interesting is because we didn't just set goals for all students. We had to set goals for subgroups. And ESSA, that is a new element that's, I think, really important when we're thinking about how we're serving all students. ESSA requires us to gather data and report data and identify students based on their subgroup. Indiana has been a leader in this for a while. We've been gathering information on different student subgroups for a long time, but right now with ESSA, we were required to set goals around those subgroups. And so what we decided to do for all of our goals is we decided to set common goals for cutting the proficiency rate of all students in half on all of those goals. So if we had, I don't know if I have this slide on here, no I don't. So if we had all of our students achieving, now I'm going to do math in my head, which is a scary thing, but if all students were at 50% achievement rate, and our goal is to cut that proficiency rate in half, then by 2023, all students would be at a 75% achievement rate. And we felt that setting proficiency cut goals like this would be more fair to all students in all different categories instead of having a common goal for every single student. So instead of saying all students will be proficient in 2023 or achieve a 90% proficiency rate in 2023, we decided to set goals based on where students were at. So if our English learners were at a lower rate than our Asian students, then we would be able to set goals based on kind of where they sit right now and target supports around that growth. And so that we set those for all three of our areas. The other, first, are there any questions about our long-term goals before I move on to our next section? So one of the other areas that's important to note is our accountability system. Now, I want to distinguish something here. For the 2017-2018 school year, we will have a state accountability grade and a federal accountability report. And then the reason there's a difference is because we're transitioning so many things in the state, we wanted to honor what we had to do under ESSA while understanding where we are as a state, and so we're going to have two separate lanes for 1 year. The federal grade is important because it determines how we spend our school improvement dollars. And in order to identify schools, we had to follow very specific federally required accountability rates. Many of the things you see on here, many of the weights that we have on here, are consistent with practices we've done in the past. So proficiency is on there, growth is on there, our graduation rates are on there. Those are elements that have existed before. What's different is that we had to add an assessment for English language growth to proficiency as a part of our accountability grade system, and another non-academic indicator that every school had to include. And so for our K-8, and I'll go into a couple of things in more detail, but for our K-8, 42.5 of their grade will be based on proficiency, 42.5% will be based on growth on their test, 10% will be based on that English language growth to proficiency score, and then 5% will be based on the non-academic indicator that we ultimately chose, which was chronic absenteeism.
Was the English language inclusion of that proficiency marker part of the federal requirement?
It was, and the percentage was also based on our interpretation of the accountability piece. We had to have a significant measure of English language growth to proficiency, and what we've seen in other states, 10% was what they considered a significant threshold.
Thank you.
For high school, we have our graduation rate at 30%, our college and career ready rate, which is a combination measure of the students who are in AP Advanced Placement, International Baccalaureate, dual credit, I'm not missing it, and that's of today, right now.
Moving targets.
Yes, these are all moving targets. All this is subject to change. But we have a college and career ready rate based on students who are in those categories. We also have assessments, proficiency on the state test, which is currently ISTEP 10, but we'll be morphing to something else that we're still working on, as Dr. McCormick says, moving targets. And we also included the English language growth to proficiency for high school students. I know that was a whole lot, but there are a couple things I wanted to dive in on for you that I think is really more focused on the goals of this commission. One is our non-academic indicator of approaching chronic absenteeism. Now, for those of you who are familiar with chronic absenteeism, this doesn't fit the classical definition, but it does address the issue in an interesting way that I think is supported by all of our stakeholders, many of our stakeholders that we've engaged. We expect, in order to achieve this measure for a student, they have to meet one of two categories. They either have to be a persistent attendee, which means they attend at least 96% of the school year, or they have to be an improving attendee, which means they have increased their attendance from one school year to the next school year by at least 3%. We like this measure because it honors students who are at school for the vast majority of their time, 96% of their time. But we also are really encouraged by the idea of the students who are increasing their time. We looked at a lot of different measures, a lot of different potential measures, and came to this one because there is a lot of research, as you know, around attendance and the importance of that in school. There's also a lot of common sense about attendance and the importance of that in school. It was a measure that we could readily have available, and it was something that schools have considered in previous iterations, but is something that they look at closely. In order to hit the 5% threshold for a school, to get all 5% of their points, a school must have at least 80% of their students meeting one of those two indicators. The other thing to note is that we don't want to, we want to be cognizant of students who transfer in at different points in the school year. So the student has to be at the school for at least 90% of the school year, which in a 180-day calendar is about 162 days. What questions do you have about this indicator?
I have a question, maybe not about this indicator, but graduation rates for the next segment.
We will get there.
Okay.
That's on one of my other slides.
Great, thank you.
Yes.
So the kid that drops out of school becomes homeschooled, for example, because the parents just won't bring them. You see this a lot in little kids. You know, I, as a prosecutor, had issues with some of the rural single mothers who just wouldn't get out of bed and bring their kids to school. And when you started cracking down on them, you know, under the compulsory attendance law, they simply reverted to homeschool. And so, how's that going to factor in? You're talking about this 96% attendance rate. So if you're a kid and all of a sudden, because you're not coming to school regularly, you're getting in trouble, and the school's going to be punished for this, right? I mean, they're going to be scored badly. I mean, I can see even school administrators encouraging that child to be homeschooled. I mean, how are we going to factor those issues in?
Do you have any?
Sure. So what we're doing right now is obviously we know we have pockets around the state where that is happening, and we are monitoring that. We are auditing those schools. You know, Indiana, as far as homeschooling, doesn't have obviously very strict laws as far as enrollment and expectations around homeschooling. We can have that conversation later. But what I will say is we are monitoring that situation in those schools where the situations you are referring to, where the students get pulled out of school, they say they're going to get homeschooled, they return to your school 6 months later and haven't done a whole lot. Right. And so you are right, the system has created, unfortunately, it's hard to get around this, where the schools will get penalized for it. We rely upon good folks like yourself and some other folks to help us with the home issues of it, but really there is no penalty per se on the student as far as accountability, but it is on the school.
What is, if I may follow up?
Go ahead, Mr. Powell.
You know, we used to have county attendance officers, and sometimes schools had attendance officers. What are schools doing now in Indiana to enforce the compulsory attendance or monitor it? Are they just simply relying on law enforcement to do that, or are the days of the county attendance officer gone?
It's really difficult, I will tell you. You police it at the school level, you try to get outside assistance with that. We also are battling at times in certain pockets of the state the letters of incapacity, where you can go to any doctor. They can sign off on, for really interesting reasons, why the child is excused to be out for a long period of time. And so that's part of the whole conversation. So it is very difficult. We are still chasing attendance.
Yeah, as a prosecutor, this is where we lost kids early. You know, these kids that quit going to school ended up in the court system and just failed. So,
and there are some counties that are pretty aggressive with it and others that are very hands-off, and a lot of the times it's about capacity. You know, where they don't have the means or the manpower to go chase attendance, and the schools are saying, you know, we've done everything we can, we've done home visits every day, you know, we're doing everything we can do, but we don't have that power to make them come to school.
this seems to be an area to me that we could work on.
Yeah.
You know, statewide, juvenile probation cases have gone down. You see fewer felony arrests, fewer kids in detention. Maybe we need to revamp this, because when you look at this is K to 8. You know, first graders not going to school because it's first grader's problem. So maybe we need to look at, get your information and look at capacity within our probation departments. And I'm not saying for first, second, third, fourth, but you know, middle school, 6th, 7th, 8th, I mean, that's when we lose a lot of kids. And whether the juvenile justice system can give some assistance. For a while there, DCS was screening out, Mirabette's not here so I can't pick on her, they're screening out junior high students that weren't going to school. And I think we're missing a real at-risk population by not. So as you look at this and it's being K to 8, maybe we need to work with you. With the juvenile, you talked about you didn't have the hook. Well, sometimes the coercive intervention of the court is a good thing with regard to a diversion program. Maybe we need to look at capacity, see how we can help.
Probably conversations with the medical world as far as some of the stuff we're seeing happening with those letters of incapacity. And I'm not saying some aren't I understand some of them are very legit and understandable, but we see some of that, I'm sure.
I saw that too as a juvenile judge.
Yeah.
I'm wondering also if there needs to be, and I've had this issue recently just locally, and I want to thank Mike Brown for getting a bunch of data for me, and for my husband, who's a prosecutor, who's facing, some of these issues locally. And one of the challenges I think that prosecutors are facing in helping the school systems is that there isn't a universal reporting system on what gets reported as an absence and what doesn't. So you have cases where some schools will accept a doctor's excuse only, and some schools will accept a parent's note in addition to a doctor's note. And so because there's not a universal absentee system, then it makes it difficult to process that locally, because we have three corporations in Washington County, right? And so how does the prosecutor take 3 different types of policies on absenteeism and turn that into helping?
Yeah, we're often totally relying on the school letting us know. We'll send someone out to check. So at least we did. We had an investigator that did that. But I had 5 school corporations, and some just never told you. So there were some schools where we just didn't enforce anything.
Or they each have different standards on what is an unexcused absence, and that makes their job a lot more difficult. We're not going to allow that, but, she's on.
She's the task force chair.
Oh, all right, go ahead then.
I'm sorry, I'm also a state attendance officer. So what we've asked some counties to do is to form coalitions so that they have common definitions. But to let somebody mitigate for student absences, like mandating discipline, something new comes across all the time. And one district takes fruits and absence for one reason, and another district for another. So many counties are getting together and working with their courts and working together as a group to have attendance panels or some sort of group that works together as far as looking at what they'll see, what they want, and what programs are put in place to determine what's happening with that family and providing family support. Marion County is probably a very good example of their parent impact panel that does work to find out what the root of the absenteeism. So I would be very being prescriptive about excusing and not excusing absences, because that takes away that local control. Does that make sense?
It does. I'm not sure I fully agree with the position, but I appreciate your input.
Maybe we could look at some joint pilot projects between probation and the school systems to target some of these at-risk kids before they get to the letter that goes to the prosecutor. So your middle school student that's hit that 5-day mark without they could work together to come up with the criteria and start getting them in on either a dual status model or an informal adjustment kind of model before they rise to the level that the prosecutor is looking at 10 days and sending a letter.
I think an informal adjustment process
We might be able to work together
would
to
be.
do
And I
a
cannot
pilot.
emphasize enough, we've got to get the medical folks involved with that conversation.
Yeah, I think an informal adjustment process would be appropriate for that. That's the step before a an official court intervention, and
Court light, maybe.
Court light,
Get
yeah.
there, yeah.
And maybe some truancy mediation to go along with the intervention or the prevention nature.
Target areas that were.
We could come up with a pilot program to address this issue. I think I appreciate Mr. Powell's bringing that to, our attention.
Well, if
and
you lock
trying
the
to
parent
address
up for not sending the kid to school, then the child often becomes a chins, right? And you have another set of problems, so.
Well, and I do think, I agree with Chief Justice Rush, that we probably don't want to have DCS screening out those middle school-aged kids who can't get themselves to school. Those are kids that have to often rely on either getting on the bus or their parents getting them there to school, so.
And I think a lot of localities, if I may, try to look at the elementary, younger kids, maybe going the DCS route and having the help of the prosecutor work with parents, and then probation maybe taking the 12 and ups.
Right.
If they're resistive and refusing to get on the bus, and then we kind of work with law enforcement to try to help get them there. That's my
The
opinion.
DCS is such a crush right now with having a 200% increase in children's system, particularly focused on drug prices. I'm afraid these kids are falling through the cracks. So I think we need to take a look at it. And I know we've got some of the task force chairs on improving educational outcomes. Maybe we need to look at between the dual status kids somewhere, but look at a focus on truancy.
I agree. Okay.
Excellent. One other thing to note on this slide, we set the weight at 5% so that it wouldn't necessarily impact someone's grade heavily one way or the other. We're interested to see how this rolls out when we're looking at the federal accountability grade, but we wanted to at least honor the fact that this is new as of this year, that we have measured attendance in the past, but in terms of the index approach that we're taking, this is new. So we set it at 5% and we'll see how it goes. The other thing I'd like to note is there was in a lot of our stakeholder discussions, there was a desire to include some sort of survey as a part of an accountability system. For those of you who have research backgrounds, when you combine surveys and accountability, that can get a little dicey. So there are some states that are just going ahead and doing surveys as a part of their accountability system. What we're going to do is we're going to pilot a culture and climate survey in 2018-2019, and we're going to leverage some of our attack two problems here. We're going to leverage some of our school improvement funds from our federal school improvement funds to pay for all of the schools that are under the comprehensive designation, which is our intervention designation. We're working on a request for proposal right now that will go out soon. And we're looking for a survey instrument that can survey students, parents, and teachers on a variety of issues as it relates to the school. We know that climate and culture are important. We know that parent beliefs and mindsets about schools are important. And we know that parent involvement is important, but it's very hard to identify a valuable metric to include in an accountability system. And so there are a variety of surveys that exist that have done this for a number of years. There are a variety of other survey instruments that are coming up. And so we're going to consider what this might look like in pilot in 2018-19, and then maybe make some recommendations on what we should do going forward.
If that does not include climate and culture as it relates to the feelings of teachers within the building and the overall climate of the school system and how the administration is handling that, I think that would be helpful to be included so that they can feel like they can speak anonymously about how the culture is in that school system, and then recommendations can be made to improve that.
That's the kind of, there's hope that we can gather that kind of data as a part of this. Couple of the other things to note is that, with some of the instruments that exist, there are questions that you can ask parents about how they interact with the school that gives you a sense of whether or not they'll actually come to the school and feel like it's a level playing field. For a lot of parents, in a lot of schools, it doesn't always feel like a level playing field, and it feels like they're coming onto someone else's territory. And so we want to understand how parents feel. And then what we've seen with some climate and culture surveys that have been done around the country is that schools use that data and make changes in how they interact with parents and with communities and make different choices. And so we're excited to explore this more, but we still have a lot of questions that are open.
And many schools are doing it now, but it's a very different feel when you're doing it for school improvement purposes versus accountability. So my concern is when you put accountability on anything, you start game playing. So as a superintendent for 7.5 years, my parents would have said, what do I need to do to make this an A? So whether it was, that's how, but in some districts, it would be different. So I really wanted valuable and just real data, but that's when you stick it into accountability, boy, that's a risk.
So it looks like I pulled the slide out on the graduation rate, but I know that was a question, so I want to address that. I don't want to address that, but I will. So under ESSA, ESSA says that the preponderance, the students that get the diploma that the preponderance, sorry, I'm not a lawyer, so I'm trying to walk through my legal language. The diploma that a preponderance of students receive is the baseline diploma that students can receive. So in Indiana, a preponderance of students receive the Core 40 diploma. And so therefore, as a state, according to current interpretations of ESSA, we cannot count our general diploma because it falls under that preponderance level. And so 12% roughly around the state of our diplomas will not count for the federal measure for our grade. Now I want to be clear about a couple of things. Our students who receive a general diploma still receive a diploma. They can still mark in a job application that they've received an Indiana diploma. But it impacts our federal graduation rate, which is the graduation rate we report to the Department of Education. It's the rate that everyone around the country will use when they compare us with other states. And so we're working a fine line. Dr. McCormick can probably talk a lot more about what she's been doing. So please.
It's been interesting because for economic development as a state, we should be very concerned. It's beyond just what's best for schools and communities. It's as a state. So when we did our homework, our general diploma requirements are much higher than some of other states' baseline requirements that have already been approved through ESSA. So our general diploma exceeds the other states that have been approved. So if our general diploma kids would move to another state, they would be included in those rates. So we're kind of up against some interesting dynamics. And so what we have done is we put in for a federal waiver. It is currently out online. We're taking feedback for 30 days as federally mandated, and then we'll send it on, and we'll have 90 days to hear back from the feds. To be honest, we're not holding our breath. So we were hopeful when ESSA went through that we would have some state local flexibility, and I will tell you on many levels we're not seeing it. And so, but we're going to put through the federal waiver to see if we can include those students. Probably what will happen is we will need legislative help for that. So, but we have had many conversations to say, what does that look like? Many states have gone to a single diploma, but looked at those tracks to keep those intact to recognize those students who are where they're falling in that academic pathway. So we have a lot of work to do in this, and we're on short time, but I'm just very concerned as far as a state, the economic impact when employers go out to say who's falling where. It's really not apples to apples when they're doing those comparisons, but many of them don't realize that. So I think it's wise of us to try to put in the waiver and to try to address it in our General Assembly. We can't do that as a department. We can't do it as a state board.
As it relates to the graduation rates and the types of diplomas, we created a lot of different tracks, graduation tracks in the last legislative session. Is that impacting ESSA at all in terms of how we compare to other states? The number, we did several different pathways.
So the pathway panel ended yesterday with their recommendation. That's going to go to the state board in December. It's hard to do that comparison right now because given the current situation, we will, not knowing how that's going to play out because we don't have all of the data to do a true comparison because some of it's new. What districts are doing now is running their numbers and taking into account the true comparisons we can make on data that we do have. We'll see some significant drops.
I'm hearing that from some of my constituents.
Yeah, and you have a lot of, the field's very nervous and done a great...
Drops in what?
Drops in their graduation rates. So in addition to the general diploma drop, then if you have the local drop on top of that, just because some of those pathways are very suited to high-performing or middle high-performing, then what? Mm-hmm. So there is just more discussion to be had regarding that whole arena, but the grad rate federally is under the waiver. Then you have the grad pathway rate that's being discussed as a state. So that will be a decision of the state board, but we may have to go back to legislators to maybe get some help. So
yeah, I'm concerned about that because some of my folks that I've heard from are reporting when they're crunching those numbers and doing the comparison, 30% decreases in their graduation rates, which would be terrible for economic development purposes.
And I was a special ed teacher for 10 years, and we have a large population of students who fall under English language learners, and I'm very concerned about the special needs populations, our most at-risk populations. I think there's some avenues we could play some games, but is that really the intent? So we have a lot of conversations to happen about the grant pathways. I think there's some good ideas that have come out of that pathway, but how that comes together and how that is implemented, a lot of questions.
I'd be happy to talk with you, Dr. McCormick, or others about what, if anything, we need to do legislatively to help address some of those concerns as it relates to this too.
Thank you.
Perfect.
So school improvement is another category that falls within the work of the commission. Under ESSA, there are two categories for school improvement. They are comprehensive schools and targeted schools. You may have heard the terms focus and priority that were used under No Child Left Behind. These are a little bit different than that. So schools that are comprehensive support kind of fall within the same general category as the focus and priority schools. They are our schools who are our lowest performers, who will receive significant support from the department through our Title I School Improvement Grant. I will say that the most rigorous interventions that the State Board of Education has strong jurisdiction over, we still maintain that fluidity between what the Department of Education does and what the State Board of Education does. But comprehensive is kind of that one step before you get into the space of the state taking some dramatic intervention. We're still working through the types of interventions we're looking at, but for comprehensive support, that's kind of that broad category. Do you have anything you'd want to add on that at all?
No, just that, with the new accountability system, it's all under rulemaking right now, and what I've quickly learned over my 303 days, we're counting, is that things move very slow through rulemaking, painfully slow as kids are moving through. So under rulemaking, we have a lot of decisions to make about accountability, which will impact all of this.
And that will specifically impact the schools that are considered comprehensive. Targeted is also, it's a new definition that I think is really important for advocates for children to really understand, especially advocates interested in underperforming subpopulations. A school is considered targeted if they have one or more underperforming subgroups within that school. So you could be a C-rated school and have a subpopulation of English language learners, for example, that are underperforming, and you would be considered targeted. Now that is obviously not as severe, and severe is not the right word, but that the intervention will not be as rigorous as you would under comprehensive or the more rigorous intervention that the State Board is responsible for. But there is a newfound focus on subgroups and a new designation. The important thing for schools and districts to understand is if you have that subgroup that's underperforming after 5 years, they are actually moved to comprehensive support. So you could be still overall, your students are doing okay, but if you have that subgroup that's underperforming chronically over 5 years, you may be moved to comprehensive support.
This is another area we'll need legislative help because we're currently under state accountability for a letter grade and the federal accountability, which is totally different for a score, which will become a letter grade basically, so, but they have different consequences.
Yeah, that was my question. What are the consequences for a failing school?
So if you have 4 years of an F, you're into takeover. So we kind of, and that's a new timeline.
Take over by who?
The State Board of Ed intervenes, basically the state. So we have some taken over for fiscal reasons, some taken over for academic reasons. I mean, our goal is not any of that. So, but if after 4 years, which we have many on that time, we have some under it already. So our concern is if you have different grades, you may be a C under one accountability system and an F in another, explain that to your community and your parents. So our charge is to bridge those into ones, which I think is the intent, and I think that's where everybody wants to get, but we have to have legislative help to get there, so we're not running two parallel, very different accountability, very different consequence systems. And so that would have to happen like now, because really that's going to be, you have monies that are determined by that, you have your letter grades, I mean, there's just a lot that falls into that could cause some really great confusion if we don't go into one.
One other question. Have you done any kind of assessment based on your current scoring of how we're going to be? I mean, are we going to have 20% fail, 5% fail, 1% fail? Have you looked at that, what the future might look like?
We did. We looked at, really we focused on the high schools because most of the impact will happen at our high schools. So given the graduation issue we're having that was both state created and federally created, and some of the new stuff going in, I mean, we're in trouble with our high schools. We looked at about 267 that will be in trouble.
My goodness.
So that's not really reflective of the work being done, because some of them are very good schools and some of them are being nationally recognized. But because of the system, but again, we're under rulemaking, we're under a lot of things there are a lot of moving targets, and we're taking, like you said, you run the data you have today. That hopefully will change given rulemaking. So we have a lot of work to do in a short amount of time where we've set up some schools for not a good situation.
Yeah, sounds serious.
Sounds dire.
Yeah, it's not good.
Yeah.
Is the press here? We've been sharing that message, so that isn't maybe new to this group, but it's not new.
Yeah, what do we need to do? We have targeted improving educational outcomes as one of our top priorities. And this is part of it. So, yeah.
We're working hard.
When you say 270,
67.
what percent of our high schools is that?
I can get you a firm percentage.
How many do we have? I can figure it in my head if I know how many we have.
Well, that's what I need to get. I need to get you a number. Mike can get that number for you. We'll get that here in a minute. I can get you districts. I just can't get you high schools because that's totally different.
Gotcha.
So on the brighter side, we do have a new...
We have money.
Yes, we do have a new funding opportunity through Title IV. This is new from the feds. It is to fund innovative approaches to support the whole child. And so schools and districts and consortia and groups of schools can apply for funding from the department to address innovative approaches to a few different objectives. So I don't have it up there, but there are kind of 5 categories that we're looking at for this funding stream. We have STEM, we have CTE, we have literacy, which is reading, we have college-bearing credit courses, dual credit, IB, AP, and we also have, which is most important to this group, social and emotional supports. And so schools can apply for these funds from the department. The downside to this funding opportunity is that for the whole state, we have about $6.5 million to spend. Just as a comparison, Title I has, I think, 250 million, something like that, comes from the federal government. So this is a small tranche of funds that we have the ability to leverage. The way that we've approached this year is a competitive grant process where schools and districts can apply for funds in a competitive way, so we can really identify and celebrate some of the innovative ideas that schools and districts are coming up with. I can't answer so much how that's going, but one of my colleagues is actually here, and she can come and take any questions about where we are in this grant process, and this is pretty fresh news.
We don't have time for many questions because we need to move on to Dr. McCormick so we can finish on time. But if there, to the extent that there are questions, we can take a couple. Okay. All right.
That's all I've got. Thank you.
Thank you. Okay, moving on to, we've already heard from Julie Whitman, so we're going to move to legislative update from Dr. McCormick.
So I don't have a whole lot to share today because of obvious reasons. So with the governor's rollout and because we're waiting on a couple of things. But one thing I do want to share with this group, just to put it on your radar, obviously the governor's very concerned about a 21st century workforce that is skilled and ready to go. So we believe that that means really a very systemic, very broad focus on quality education. Regardless of what type of school you attend, they should all be of quality. But we also think too that includes kindergarten. So right now in Indiana, we have about 8,000 kids who do not attend kindergarten. And so we're a little bit concerned. I know we're concerned about the other end of the general diploma kids on that 12%, but then we have about 9% on the other end who aren't attending kindergarten. So we are watching their numbers as those kids progress through to see how they're performing on some assessments and what is that looking like. So we are concerned. I know some of the pushback that we're receiving is as far as that age piece, but we still have the provision, as you brought up, as far as if families feel like their children aren't ready at the age of 5, or if they're not, prepared for school, they do have that homeschool provision. Those aren't really the at-risk kids necessarily that we're super concerned about, those that have the means to truly do homeschool at home. I'm concerned about the ones who don't have the support at home. And so I think it's time. There are only 14 states that require school to start when they're 7. We still have kids that walk in the door that aren't potty trained, that don't know how to hold a book. And if we're truly looking at a high-quality workforce down the road, and we're looking at an SAT or an ACT as a college or as a high school kind of exit type of exam, it's going to require us to backward build. So we're putting a lot of funds and a lot of resources to pre-K, which we completely agree with, targeting our at-risk students for pre-K. But I think that kindergarten piece is very concerning. So we are looking at that. We're crunching a lot of data, but we're getting kind of noisy, because if we're going to set our schools up for success and our students up for success, I think the preschool money is being spent well. Many of those who come through the program, it's an expectation they go on, but we're still not servicing all kids in that means. So there's just a chunk of students every year. It runs about the same trend that we're watching who don't attend. Some come to first grade. We're watching their attendance when they do hit first grade. Are they even attending 162 days? So we're watching some of that data coming through as far as, is it time for Indiana to look at that? So we're having those conversations that the kindergarten piece is big, and we have other issues, obviously, that you heard today that we're going to need some legislative help with, but we're being very respectful and cognizant of the governor's rollout and the time of that. But I did want to share the kindergarten piece from our point, as far as it is just a common sense continuation of, if we're going to have high expectations at the end, it's got to start at the beginning. So we're having a lot of conversations about it.
Thank you. Any questions?
What age are you looking at? If you could give 5 things, the 5 things could change to make education stronger in Indiana. What would you do? Just the magic wand. What would they be?
So if we could just take control of all of it and do what we needed to do, obviously we would have a big focus on pre-KK, because we have such a gap coming to us in some of our most at-risk areas. We're also watching it by county, because we were seeing if there's a drug overlap to that. So we're having all kinds of conversations. So the pre-KK focus is big. Being able to tackle curriculum and instruction and the credit requirements within the diploma types, looking at diploma types as far as pathways to one diploma, allowing flexibility for districts within that. I mean, there's, allowing more training for teachers and content. Obviously, the pipeline's a concern. And I know money's not growing on trees, so I'm not going to be critical of our General Assembly. I mean, everybody around this table always wants more money. So, but the financial issue to entice people to come into the field, but we need flexibility in that spending, which we got a little bit of that in 1009 last session, but there's also other pieces of it that still tie our hands. So I know it's way more than 5, but there's, I could go on.
You have 2 more.
Any other questions?
Yes, I do. So you're looking at starting the school age from 7 to
5.
All right, thank you. Now we'll move on to Catherine Dolan for the communications plan, which we will be asking to approve as the commission.
Good afternoon, Commission. Thank you so much for reviewing our communication plan. We are hopeful that you will give it approval today, and I'm very pleased to tell you that we do have Kristen Casper from the Public Defenders here, as well as Jim Gavin from FSSA, along with other individuals from many of your agencies who helped put this together. As you know, when the strategic plan was put in place, communication was a key factor, and we fast-tracked it. We met on a monthly basis and really tried to tee it up in a way that we felt provided whoever would be named the executive director an opportunity to put their stamp on it in an effort to present it to you. And we are very pleased that Julie Whitman just really took to it right away and reviewed it not only with our commission, with our subcommittee, but we also met a few times to go over it. The overall plan, which you have seen, really supports the overall commission in achieving its goal. We're looking to promote the alignment of the stakeholders, prioritize communication, and ensure that we're using the resources that we have afforded to us effectively. We spent an awful lot of time, as you can see in the actual plan, talking about internal versus external communication. And internal is really where we decided we needed to put a lot of emphasis and concentration. Strengthen the communication among the communication itself, the task forces, the standing committees, and the partners. And you'll see in the plan a lot of that communication now flows through our new executive director, which we're quite pleased with. In terms of external, advancing the work of the commission through our external audiences, primarily the non-government entities that have a stake in your work. And these are the two sides that we really felt we needed to concentrate on. Our key messages need to be reviewed, and I think that review could take place on a yearly basis, but right now these messages are heavily based on the actual strategic plan. Our mission, our vision for every child in Indiana to have a safe and nurturing environment. Our goals that we are working towards through our four subcommittees. The emphasis on the collaborative nature of this, which all of you have talked about, and that we're already having an impact. We can point to, for example, the Children's Commission app. So we do have key messages that we need to get across. And of course, the question is then, how do we do that? So the sort of meat is on the bones in the actual plan of how do we facilitate that communication, establishing the vehicles for the executive director to communicate with you through the task forces, the committees, establishing the specific vehicles. We wanted to leave it general enough that we didn't tie anyone's hands on what could be done, but started put the parameters in place to give ourselves the opportunity to ensure that those lines of communication are open and continuing. And also leveraging our stakeholder networks. For example, as it relates to the judiciary, if there's something that takes place today that needs to be related to probation, how do we as the judiciary make sure that that message doesn't just stay in this room? What are our vehicles to make sure that that gets down the line to individuals who have a stake in this? And so again, in the communication plan, we sort of lay out that that needs to take place. And we give the executive director a lot of authority and autonomy to make sure that those lines of communication move forward, to get to all of our agencies and our partner agencies. And that's where we say develop the vehicles to effectively communicate that. Overall, I can tell you that your PIOs are committed to this, have been engaged in this process, and as we get information out to the public, I actually think in some respects that that's a little bit easier than the internal piece. And that's, again, why I want to bring your attention back to that. It's sometimes simple for us to get out a press release, but are we telling the people who need to know right here in our own agencies? And so I'm happy to answer any questions as it relates to this plan, but this is the plan that we are asking for approval on.
Okay, thank you. I guess we have a couple of questions about when would it be appropriate for you all to report back to us the progress of your plan? Is that going to be something you think you could do quarterly as far as how you're meeting those goals, or at the end of 6 months or the end of 12 months? What is your view on when would be a good time for you to report back on how you're meeting these goals?
You know, we did not discuss that specific timeline, and I think what we were frankly very dependent on is getting advice and guidance from you all and working with Julie on how those specific vehicles maybe need to be shored up a bit. I have no problem with a report at any time that you'd like one.
I think it would be helpful if the strategic plan for the communications is involving the development of vehicles that we're not naming, right? Or we're not determining. There's a lot of things in here that we're saying we're going to do, but we're not defining. And so I think it would be helpful, probably in the next quarter, to have an idea of how we are further developing the tactics, if you will, toward the plan.
And if Julie wants to weigh in on this, we talked a lot about, we kind of got into the minutia very specifically of, well, maybe it will be a weekly newsletter that Julie would provide to the commission members. And then as we got into that minutia, it seemed short-sighted to proclaim that she's going to do a weekly newsletter when she's at the 15-day mark into her job. That seemed a little short-sighted, and so that's why we pulled back a little bit to give a little breathing room to say, look, we know that here's where we want to hit these markers, but the actual vehicle by which we would do that, we wanted to not handcuff ourselves.
I think that's okay. I would just take it in the next step further before, maybe even at the next full commission meeting to say, what have you determined that how those communications are going to take place?
Right. I fully agree with you, Senator Houchin. A lot of this plan is saying we are going to establish these things. Right. We're going to figure out what our processes are going to be. And the second handout you have behind the plan is the processes that we have already started to flesh out. So we have some of those for you. But you're absolutely right. It's as a plan, it has no value until we have those actual vehicles and things we say we're going to create. So happy to report back on that.
I think that would be helpful for us, because if we're waiting, if we have this plan and we approve the plan and we're not coming back to discuss the plan until next year at this time, then, we're going a whole year without determining really what our communication, and how we're going to be meeting our communications goals. So I would like to see us have some kind of information back on further defining how we decide that this is the best way. And maybe we don't have to have a hard and fast rule to tie your hands, but I think it would be helpful to have some guidelines, what kinds of communications we're going to have and in what methods. Yes, Senator Bro.
I'm just curious. You have down here, ensure resources for communications are utilized effectively. What resources do you have?
People, right? I mean, that's a great question. That's one of the things that we talked about. So the resources right now would be those individuals that are coming to the table who are PIOs or communication professionals, myself, Jim and Kristen who are here. We've had Jeremy Brilliant from the Attorney General's office who's been engaged, Ike Randolph from DOC who's been involved in a lot of our conversations. And I fear that I'm forgetting someone, but a good example.
You don't have a budget though. Do you need a budget to effectuate this?
All the agencies, like Catherine is our public information officer, so we are asking our existing public information officers to work together to have that message. And the plan is in this. It's pretty detailed. We had a consultant, and thank you, Casey, who paid for Claire's to come in and consult. They spent a day. They've met a number of times, but we're just putting this on their already busy backs.
So one thing that we already did, we have taken some steps. We've developed a media list that was refined from each of our individual communication lists to ask press members, are you interested in specific information about the work of the commission? And we had about 40 or 50 press members return back to us, yes, I want to know what specifically is going on with the commission. And so in the past, I had been the one who would send out information saying, want to remind you that the meeting is taking place next week. This past time, Julie actually contacted our 50-member press list and said, we look forward to seeing you next week. I think that's a great step to give them access to the person who they can get information from and to be transparent and sort of pushing of the information to them. I know also when Julie met with individuals, she asked some of you, do you have anyone you want to add to the press list? And so we're trying to keep that updated. We talked about how would we manage press releases going out. When we did the app, I put together a press release. I had my colleagues from the different divisions take a look at it. We made some refinements, and we got it out. Well, what does that process look like under our new schematic. And so we talked very specifically about having Julie bring the press release to the executive committee so that there's a structure in place. So I think that the finer points are in there, but we did leave a little bit of wiggle room, if you will.
And some of them do need to be developed.
Okay. And Julie, what would you feel would be an appropriate time to begin to develop those so we have an idea of what that might look like? Okay, so maybe by the next commission meeting, you'll have another update.
We'll have a progress update for sure. I can't
That'd be
say
great.
it will all be done, but
Okay.
yeah.
Well, I appreciate the work that's gone into the plan. I think it's really, I mean, I've enjoyed going through that and seeing where we're headed. Just thought that there could be a few more points delineated. It sounds like you're working on that as we speak, so I appreciate that very much. Are there any other questions for Catherine? Okay. With that, I'll ask for a motion to approve the communications plan. Is there a second?
Second.
Okay, all those in favor say aye.
Aye.
Any opposed? All right, thank you very much.
Thank you.
The next item before we adjourn is discussing future meeting topics or other items from commission members. The only one thing I did pick up on is for a future meeting, we might want to go back to what Mindy Goodpaster made a presentation on to follow up on those recommendations from the task force. So I think we want to make note of that, as well as Mr. Powell brought up, and as well as Judge Willis, the issue of attendance, and maybe that's something we want to discuss as an executive committee to see about whether the Educational Outcomes Task Force might want to look at some kind of a pilot recommendation.
Or the dual status.
Or the dual status,
Or
right,
maybe a
right.
combination.
So that may be one that we want to include.
And I understand it's got a fiscal, we don't always just look at the fiscal, but I'd like to look at the 5 versus 7 and start studying that now. And get the weight of this commission behind the issue and have a
It will need it. We've been trying to do it.
recommendation for it. So you've got the different agency heads and branches of government weighing in. I know we've got some of the educational task force, maybe they can do a presentation, we can look at it, you have a recommendation of the Children's Commission with regard to change it. I mean, you start that, you gotta start that wheel now to, if we're thinking about doing it X amount of years from now. That's a great idea.
One other thing I would note is the Health Department's presentation on the instance of marijuana-exposed infants. I know that there will be at least some legislation proposed in the next session to try to legalize marijuana at some level, and I do not want to neglect that as part of our discussions, something that the Executive Committee probably will be discussing in the interim, but I want to at least open the door for a discussion on that during our next commission meeting.
Why I had that, I'd also like to look at the opioid crisis and Nita's hidden victims, the collateral consequences of the opioid with regard to, one, its impact. There's some definite information with regard to the number of children in care on the opioid, but there's not a lot of talk of the opioid crisis in the impact on children. So I'd like to hit that part in the front end of the year, because then we can say, so what are we going to do?
And ultimately,
question over here, Senator.
Sorry, Senator Brown.
Just to tag up on that, I would really very much like to have maybe Dr. Wathall or someone from the Department of Health give us sort of a breakdown of the stats as it relates to the addiction and opioid crisis. How much are we spending as a state? How many are, what's the ages of these addicted babies?
Yeah, we'll figure it out.
And just a presentation that gives us
we did talk
addiction
about
broken out by the numbers. And then my other question, which is unrelated, which I don't know if it applies, but I mentioned this to earlier, is that I was watching the program and it was talking about Indiana has a backlog of foster children because foster parents are no longer accepting them because they have not received any kind of funding. Is that something that we as a commission need to be intervening on or addressing, concerned about?
I have not heard that. I do know that we have Representative McNamara chairs the GCS Oversight Commission. That might be an issue that we get to her.
Yeah. Okay. Anything else? Yes.
Just a
suggestion for a future topic. There's a place to fit it in. I think the awareness of how trauma affects youth in regard to physical health, mental health, behaviors, as well as families, and how it can be generational, is becoming more prominent. And I think the more information we could have on this to utilize in looking at all of the areas would be really, really helpful.
Thank you. Dr. Box, would you and... Yeah, Dr. Box, pay attention, Dr. Walthall.
Proud of you.
Excuse me, Dr. Box. No, my question is, not to interrupt, you're perfectly fine, you're in order. If you and/or Dr. Walthall will be making a presentation or at some point making a presentation on the request of Senator Breaux on the deeper
That's what we
dive
were
on those
talking about.
stats,
Yeah, we were discussing.
would you be prepared to do that as soon as February 14th, or would you
Sure.
need another date?
Absolutely.
Okay, all right, great, thank you. Anything else? Judge Willis. I almost called you Dr. Willis.
No.
So many doctors.
About half of the commission also is designated to be participants of the RJOI, which is the Regional Judicial Opioid Initiative, which is part of the judiciary's response to the opioid crisis. And so I just wanted to give a little heads up that I may be contacting some people. We need some data to put together on that, and we'll be having a meeting in December for update and review. And I know some people I haven't met yet are designated to be on there, and I need to meet today, and several others that have been on the RJOI initiative and would be invited to participate again. And obviously, children are a subset of that, as the parents' opioid crisis affects the children that are born into them. So this was a good platform to make that announcement that notice is coming.
Thank you.
I have one other quick request. I was asked by the Conference of Chief Justices in Perinatal to chair a national opioid task force with regard to the judicial response. I am collecting, so any information that you have to collect, there have been all types of entities nationally, the National Governors Association, the National Association of State Legislatures. There's been a lot, but connecting the dots with regard to this population in our courts that we're dealing with. So you cannot send me too much information of what you have. I've not seen in my 30 plus years a public health crisis of this magnitude right now. So the more information we can get, the better. And as you roll out the NAS and the drug addicted, or the children who have drugs in their system, I'd love to keep seeing that information. Because I have to think that, you've got a small sampling, and here's a sample for small sampling. And what a great time to intervene if you can intervene at birth by knowing that the child is, I worry about all those other ones
That program actually tries to intervene in the first trimester. When we very first see that patient, we're actually urine drug screening.
But so many of them aren't even getting care in the first trimester.
Well, but there are a significant portion of women that are. So women can always opt out of being tested, but we're just kind of just like HIV or BDRL for syphilis, RPR, we're just automatically saying this is part of your screening, and we're screening. Because we know, just like HIV, we can intervene at that time and make a difference in the severity of the NAS and the length of the time the baby's in the newborn ICU. So that's really trying to intervene even sooner than the delivery time. But our data right now is from the courts.
Thank you. And welcome, Dr. Box.
Thank you. I'm sorry I was late. I had
That's
an
okay.
executive board meeting
That's
actually,
okay.
yeah.
Dr. Boss is
We
the...
made a note on your attendance.
Yes, we did. We noted that on your attendance, and you got called out for speaking out of turn. But Dr. Box is the new health commissioner for the state of Indiana. We're pleased to have you join us as a member of the commission. Thank you for being here. All right, anyone else for the good of the order? The next meeting date will be February 12th, 2018. Please note, February 14th, 2018, at the Indiana State Library. Please note the location change. Is there any other thing to come before the commission? Is there a motion to adjourn? Thank you. So moved.
I apologize. I have a drink first.